Perfect. Good morning, everyone. The Human Services Joint Subcommittee meeting will now come to order. Committee Secretary, will you please call the roll?
Senator Cannizzaro, Senator Dondero Loop,
Here.
Senator Hammond,
Here.
Senator Kiekefer,
Here.
Senator Ratty,
Here.
Assemblywoman Benitez Thompson,
Here.
Assemblywoman Carlton,
Here.
Assemblyman Frierson,
Here.
Assemblyman Roberts,
Here.
Assemblywoman Titus,
Here.
Assemblywoman Tolles,
Here.
Assemblyman Watts,
Here.
and Chair Monroe Moreno.
And I am here. I will let you know as soon as Senator Cannizzaro joins the meeting to update our minutes for the day. I'd like to welcome everyone to our meeting today. We have a lot of work ahead of us. It's important that we get through the 8 budgets today in a very timely manner. Before we begin today's meeting, I'd like to briefly review how our virtual meetings meet. As everyone now knows, the building is closed to the public and all participation is either through Zoom or by telephone. I ask the committee members to mute your phones and leave your cameras on so that we can maintain a quorum. Any public comment will be held at the end of our meeting, and we ask that when you call in that you speak clearly and spell your name for the record, and only take no more than 3 minutes for comments so that we can get everyone's comments in. As I said, we have a lot of work ahead of us, so we're going to dive right in. We are going to invite Director Whitley to the room. The virtual floor is yours, and we will begin with Budget 628-3244. Director Whitley, the floor is yours.
Thank you, Madam Chair. For the record, my name is Richard Whitley. I serve as the Director for the Department of Health and Human Services. Both budget accounts that I'll be presenting today cover pass-through programs to the Division of Healthcare Finance and Policy to make supplemental payments to hospitals. Starting on page 2 of my presentation, budget account 3244 is the Indigent Hospital Care Program. This program was established to reimburse hospitals for care provided to uninsured persons. The Fund for Hospital Care to Indigent Persons is administered by the Board of Trustees appointed by the Governor. The Board of Trustees include 4 county commissioners, 1 county social service agency director. The counties seek reimbursement from funds for indigent care provided in excess of $25,000. The board may also transfer funds to the Division of Healthcare Finance and Policy for supplemental payments to hospitals. Turning to page 3, this budget account receives 2 primary funding sources: ad valorem tax revenue estimated to be approximately $17 to $18 million each year of the biennium, and unmet free care obligation estimated to be approximately $26 to $27 million each year of the biennium. Page 4 summarizes the 4 allowable uses of the funds as determined by the Board of Trustees. The majority of the funding is transferred to Medicaid to be used for supplemental payments. This is expected to be approximately $26.8 million in fiscal year 22 and approximately $29.5 million in fiscal year 23, and will allow Medicaid to pay approximately $17 million in supplemental payments in fiscal year 22 and $81.5 million in supplemental payments in fiscal year 23 with the federal match. Moving to page 5, this budget account has 1 significant decision unit. E350 redirects revenue generated by the 1.5 cent ad valorem tax from hospital supplemental payments to the counties to offset their long-term care assessments. The Board of Trustees voted for this change at their February 7, 2021 meeting. The governor's recommended budget includes the reduction to hospital supplemental payments as follows. In fiscal year 22, $101.5 million to $72 million. In fiscal year 23, $114.2 million to $81.5 million. The county match program also draws federal match. So we don't lose any federal match. It just shifts from one program to another. This concludes the overview of this budget account 3244, and I'd be happy to answer any questions.
Thank you, Director. And we do have a question. Senator Ratty.
Thank you, Chair. So I think you touched on this, but if you could just go a little bit deeper into, is there any difference between the use of funding in the governor's budget and what the Board of Trustees has approved for the 2021-2023 biennium?
Stacy Johnson, Deputy Director for the record. The only change is just the truing up the projections in this fiscal year 21. So we are estimating approximately $6 million more. That will increase the carry forward in 22. The primary reason for that is the ad valorem tax. We have a couple quarters of actuals now. So we are projecting about 2.4 million for that. We also have the actual amount of unmet free care, and that's expected to be about 1.6 million more. Typically, we budget about $1.5 million for traditional claims, but this year we didn't receive any, so we have an extra $1.5 million. And then the Medicaid UPL offset is going to be approximately $600,000 less than originally anticipated. So the board did vote at their February meeting this month to split that $6 million, 50% for hospital supplemental payments and 50% for the county offset. So that's the primary reason differences between GovRec and what we see today.
Will that stay static through the rest of the session, or will there be additional updates?
Well, we're not, Stacy Johnson for the record, we're not anticipating any other updates, but as we get actuals in, the second half of the year are still estimates. So that could still fluctuate somewhat, at least in the ad valorem tax.
Okay, great. And then can you just talk a little bit about what's driving the shift of funding in this budget from providing that non-federal share in the Indigent Accident Fund to supporting the supplemental payments for the counties?
For the record, Richard Whitley, it really is that our uninsured rate, has so greatly improved with the Affordable Care Act and the coverage that people have, that we have less uncompensated care.
So then you don't anticipate any access to care issues from this reduction?
For the record, Richard Whitley, I do not.
Great. Thank you, Chair.
Thank you. Members, any other questions on this budget? Okay, seeing none, we will move on to our next budget, 3260.
Great. For the record, Richard Whitley, Director for Health and Human Services. Turning to page 6 in my presentation, budget account 3260 is for the Upper Payment Limit Program. This is a pass-through account associated with the private hospital upper payment limit. Nevada Clinical Services, a Nevada nonprofit corporation, as part of their charity care initiatives, assumes some of the department's contracted services. This creates a savings for the state that can be used to transfer to Medicaid for supplemental payments. And some of the funds are reverted to the general fund or to the Healthy Nevada Fund. Turning to page 7, this slide shows the total amount of contracts and the amounts that will be reverted. We are projecting 46 contracts, which is approximately $12 million for each year. The budget includes transfer to Medicaid of approximately $9 million per year and reversions to the general fund of approximately $3.1 million. With federal match, this allows Medicaid to generate approximately $23 million in supplemental payments. There are no major decision units in this budget, so I'd be happy to answer any questions.
Thank you. I believe Assemblywoman Carlton has a few questions.
Thank you, Madam Chair, very much. I appreciate that. So I've been around, as we've talked about, this upper payment limit holding account for a very long time, and it's a little complicated how it actually works. So it's to put it in basic English, is the money that we save by contracting some of these services out, we can put into a fund and use that to draw down even more federal dollars. What is the match currently, Mr. Whitley?
For the record, Richard Whitley, the match is the FMAP. So it's where we use that as a state share of funds for CMS.
Okay, that's what I thought. So as these contract services go on, have we identified who the nonprofits are? I believe it's like one overarching nonprofit that then contracts with some other providers to help take care of some of these issues. Is that correct?
For the record, Richard Whitley, that's correct. The overarching nonprofit is Nevada Clinical Services, and they in turn work with 46 contractors providing services to Nevadans.
And they receive money from the state to do this, but do they also receive money from providers to help manage this?
No, they do not receive funding from the providers to manage it.
Okay, thank you very much. Thank you, Madam Chair.
Thank you for the questions. Members, any other questions on this budget?
Question, Madam Chair. Yeah.
Senator Kiekefer, go ahead.
Thank you, Madam Chair. Director Woodley, I saw that the Southern Nevada MOST team was being added to one of the services that's being contracted out in this way, or added to this holding account. Is that something that is there a new funding mechanism that's allowing that wasn't allowed in the past, or why is that happening for the first time this session?
For the record, Richard Whitley, we can't use federal funding to get a match, but we can use Fund for Healthy Nevada, and so those dollars can be used as well as general fund. So we continue, like I said, there are 46 nonprofits that ordinarily would receive general fund, but the Nevada Clinical Services is actually being the funder to those agencies. We continue to review every opportunity for additional programs that may fit the criteria. We have to run those by Nevada Clinical Services. So that change with MOST using Fund for Healthy Nevada has allowed us to utilize Nevada Clinical Services.
Okay, so it's the shift in the funding source for the Southern Nevada MOST program that's allowing them to come into this.
For the record, Richard Whitley, that's correct.
Thank you very much. Appreciate it.
Assemblywoman Titus.
Thank you, Madam Chair. So I'm understanding that the Nevada Clinical Services is kind of the overseer, and the state contracts with them, and then they determine these other subcontractors. Is that correct, Director?
For the record, Richard Whitley, no, actually, these are identified agencies that the state would have ordinarily engaged to work with to provide services to Nevadans. And as part of their charity care initiative, Nevada Clinical Services is providing it. And as a result of that, we're able to use that funding then as a match with CMS for Medicaid.
So are all the, and thank you for that. So are all of these subcontractors then, must they all be nonprofit?
Yeah, for the record, Richard Whitley, yes, that's correct. They are all nonprofit.
Thank you for that clarity, because I always have some angst over contracting with folks that are for-profit on federal and state dollars, and it makes me a little anxious about that sometimes. And then I don't see on your list of contractor services provided by nonprofit organizations, the family home nurse program. Is that going to be on a separate budget?
The home visitation, for the record, Richard Whitley, if it's proposed to be funded with TANF funding, and we cannot use federal funding, to hold up as a match back to the feds with CMS.
Correct. That makes good sense. Thank you. And then I've heard sometimes different positions. I'm hearing you say that it actually saves the state money to do this subcontract. Is that what I'm hearing, as opposed to hiring the personnel that then operates into these, say, rural clinics, the hotlines, the suicide intervention on some of those things? So it makes better sense to have a subcontract with a private person?
For the record, Richard Whitley, yes, it leverages the resource.
Great, very good. I just wanted that for clarity. Thank you, sir. Thank you, Madam Chair, for the question.
Thank you. Assemblywoman Benitez Thompson.
Thank you, Madam Chairwoman. Assemblywoman Carlton and Senator Keffer kind of covered the question I had. I have no additional questions.
Thank you. Assemblywoman Tolles.
Thank you, Madam Chair. And I apologize if I may have missed this in the answers to Senator Keffer and Vice Chair Carlton, but as I just looked over the list, I know that we are increasing funding utilization of the contracts with the most program, but I see that we're decreasing in some cases pretty significantly with mental health placements, with crisis intervention, with psychiatric services, to Lakes Crossing, and I was just, and then the community triage. And so if you could just help walk me through a little bit and forgive me, I'm new to this, this is my first time in Ways and Means. So if you could just walk me through, what does that mean when I see all those decreases in those specific areas?
Sure. For the record, Richard Whitley, there's not a reduction in the services, but as I said previously, we can't leverage federal funds and hold that up as a match. So as you'll see, as you have heard throughout our department presentations and divisions, because of just the fiscal crisis we're in, we have leveraged federal funds that have a margin to be utilized in programs that we can, and to maximize those federal dollars, but we cannot use those federal dollars as a match. So with CMS, so we can only use general fund and the Fund for Healthy Nevada, non-federal funding. And so we're not reducing those services, but the funding streams, which you'll hear in when the Division of Public and Behavioral Health presents their behavioral health budget in the upcoming weeks, you'll hear more specifically about how those programs are supported. But the reduction isn't in services, it's a change in how it's funded to leverage these dollars.
Wonderful, thank you so much. And I figured that might be the case. I just didn't want to be reading that and misinterpreting that. So I appreciate that clarity.
Thank you. I believe Assemblywoman Carlton had a follow-up question.
And thank you very much, Madam Chair, for recognizing me the second time. And I think Dr. Titus pointed out a very important point. The state usually doesn't subcontract out services like this. We've not had very good luck when we've done that in the past. I believe the difference with this is, Mr. Whitley, and correct me if I'm wrong, but Nevada Clinical Services actually donates part of the cost of doing this as a portion of their free care that they provide, their charity care. So it's not as though they're in the business of doing this. This is a service that they're providing to the state, and it's a little more complicated than a regular subcontract situation.
For the record, Richard Whitley, that is correct. I would add that I know of no other nonprofit organization that would function in this role. Usually those intermediate agencies are for profit.
Thank you very much, Madam Chair, and thank you, Mr. Whitley.
Thank you. And for our final question on this budget, Assemblyman Roberts.
Thank you, Madam Chair, and I appreciate you allowing me the time. So, Mr. Whitley, you had mentioned a $3 million reversion to the general fund, and maybe I missed it, and I apologize, and I can't find it in my notes. But could that money, or was that money used to further leverage federal dollars, or could we use those funds to further leverage federal dollars?
For the record, Richard Whitley, sure, any general fund dollars could be used when opportunities exist to leverage federal dollars. I assure you that we have leveraged all the dollars that are available. This reversion into general fund, does contribute back to the general funded budgets, including Medicaid.
Quick follow-ups, Madam Chair. So if we didn't revert that $3 million, would it be eligible for federal match? And then what would that typically be?
Again, for the record, Richard Whitley. So it would be the FMAP, the federal match for the population being served by Medicaid. So it would depend on the service. If for example, you wanted to add a service to Medicaid that cost $3.1 million, depending on what the service was to what population, there would be a federal match that would be assigned to that. But again, I would just highlight that in reverting it to general fund, our programs then do, like Medicaid does get general fund. So it does come back around and has leverage capability. I guess the significant thing here is it doesn't stay in my budget in a discretionary way that I can reallocate it. It goes back into the general fund. So based on the budget in Medicaid, we leverage all the dollars that are possible with Medicaid and then revert what's left over to general fund.
Thank you for helping me understand that. And thank you, Madam Chair, for allowing me to ask a question. Appreciate it. Appreciate the answer.
Thank you. I know there's a number of new people on this committee, and maybe staff can just talk a little bit about the reversion so that everyone is brought up to speed.
By staff, for the record, Richard Whitley, do you mean me?
I meant our committee.
Okay.
Thank you. Thank you, though.
Madam Chair, I'd ask Kathy Crockett to provide that explanation.
Thank you.
Yeah, this is Kathy Crockett with the Analysis Division. For the record, I believe Mr. Whitley characterized it correctly. The excess funding does revert to the general fund or highway fund. I'm happy to provide additional clarification.
Kathy, I can barely hear you. I'm not sure about the other members, but I can barely hear you.
Oh, okay. I'm sorry.
Thank you.
I believe Richard Whitley, he did characterize it correctly, so that excess money within this budget account reverts to the general fund for general fund use and goes to, back to Medicaid or other state agencies, and the Fund for Healthy Nevada funding similarly goes back to the Fund for Healthy Nevada and then is reallocated in future years to other services.
Thank you so much for stepping in and helping out. And thank you, Director Whitley, for the presentations for the two budgets. I see no other questions on this budget, so you get off easy today and have a wonderful weekend, you and your team.
Thank you.
Moving on, next up we'll have the Division of Healthcare Financing and Policy. So I now invite Administrator Susanna Berryman to present the remaining budgets that are on our agenda today. And we'll start with the Prescription Drug Rebate, Budget 3245. The floor is yours. You can start at any time. Are you unmuted?
This is broadcast. You'll want to press unmute in the Zoom call itself.
Hello, can you hear us now?
Broadcast. This is broadcast. We can hear you. Please go ahead.
Good morning. Suzanne Bierman for the record. I apologize for our technical difficulties this morning. I just want to pause and make sure we're good now. Can you hear us? Okay, great. Thank you. Well, I'm the administrator for the Division of Healthcare Financing and Policy. Thank you for the opportunity today to present information on the budgets for the Division of Healthcare Financing and Policy, also known as Nevada Medicaid. Joining me here today are the Division's 3 Deputy Administrators, Dwayne Young, the Deputy Administrator for Policy and Programs, Cody Finney, the Deputy Administrator for Managed Care and Compliance, Philip Burrell, our Deputy Administrator for Finance, and Melissa Lawfer-Lewis, the Division's Administrative Officer for Finance. If I could just briefly have the indulgence of acknowledging that this has been a challenging and unprecedented time for staff managing through a lot of uncertainty related to COVID and the corresponding budgetary crisis. I just wanted to take a quick moment and thank staff here and the entire division staff for all of their long hours and hard work. So with that, we'll jump right in. I know we have a lot to cover today. So slides 2 and 3 here provide information on the division's mission and org chart. So if we could go on to slide 4, please. This, I just wanted to provide briefly, it's not really a part of any of our decision units, but just wanted to provide a quick update on Medicaid Caseload, certainly something that we spent a lot of time talking about through the special session and has big implications for our budget and certainly in the Medicaid and checkup budget accounts. We'll talk about our caseload projections, but I did just want to take a quick minute here to recognize the significant caseload growth that we've had over the course of the past year. You can see about a 20% growth here over the course of the last year. This is the highest Medicaid and CHIP caseloads that we have seen. So did just want to flag that and also note that this is tied to the public health emergency and some additional enhanced federal funding that the division is getting through the Families First Coronavirus Response Act that has some maintenance of effort eligibility requirements tied to it. So again, I know we'll talk more about this, but did just want to acknowledge our current caseload, and then we'll certainly talk more about projections in our budget accounts. So with that, if we could go to slide 5, please. This slide provides a very high-level overview of the division's request for this biennium. The division's overall funding request is increasing 25%, approximately $2.3 billion over our current biennium's legislatively approved budget. The major changes here include caseload, inflation, changes related to the rate restorations that were made during the special session, and changes in the other category. If you can see that one, there's quite a large change in that category, and I asked the question, what's accounting for that? And that is really due to transfer of drug rebates into a standalone budget account, which is our first budget account that we will discuss today, but did want to start with this high-level overview of our overall budget account. Next slide, please. So this brings us to a summary of the division's budget accounts, each of which we will review this morning, starting with the prescription drug rebate account, budget account 3245. Next slide, please. Here we have an overview of the prescription drug rebate. This is a new account. It is a transfer of funds that are being moved to this new account 3245 from the medical account. As you can see, revenue is over 300 million. We just wanted to provide a slide and some context that this is due to increased transparency related to the drug rebate program. And there are no decision units related to this program, but did want to flag this here for you all. Oh, I'm sorry, I misspoke. There are 2 decision units here creating this new budget account. So you can see those here, 900, which is, as I mentioned, the transfer from our medical account into the standalone budget account, and E501, which aligns revenues and expenditures with the transfer of drug rebates in 900. Moving to the next slide, please. Well, that concludes our review of our new accounts related to the drug rebate. So I will pause there and see if there are additional questions.
Thank you so much. We do have a few questions. We'll start with Assemblyman Watts.
Madam Chair, good morning, Ms. Buren. Thank you for the presentation. I just have a question about this. What's the anticipated time frame for evaluating drug rebate revenue projection methodologies?
Good morning, this is Melissa Locker-Lewis. That is something that the division began last biennium. We are continually monitoring several different projection methodologies. However, what the methodology that remains the most accurate is utilizing a 5-year trend of drug rebates that the division receives, and so that is what is included in the Governor Recommends budget.
Thank you for that update and clarification. Thank you.
Thank you. Members, any other questions? Okay, seeing none, we will move on to our next budget.
Great, thank you. Our next budget is budget account 3157, our intergovernmental transfer account. This account here collects payments from counties and public entities to pay for the non-federal share of Medicaid supplemental programs, reduces the general fund appropriations in support of the disproportionate share hospital payments that the division makes to hospitals, and collects payments from counties, county hospital districts, and other public entities to support the upper payment limit programs. So this here was just an overview of this particular decision units in this account, E350, which is the Indigent Accident Fund County Match Program. This decision unit proposes to divert a 1.5 cent tax revenue from the IAF Supplemental Payment Program to assist counties with their recent increased obligations of the Long-Term Care County Match Program. E352 here is a request to fund managed care organizations through a directed payment program, another supplemental payment program. This request is a companion to E352 in the checkup budget account and E352 in the Medicaid budget account. In 2016, just for some context, CMS issued information regarding the limitation and phase out of this prior safety net program. And hospitals were facing a 10-year phase out effective in 2017. So as a result, the division has been working with CMS and safety net providers to provide a more sustainable supplemental payment program. So I just wanted to provide a little bit of additional context on that decision unit. And the next is E678, which is the balance forward of the state net benefit. This request balances forward the state net benefit into the Title 19 Medicaid budget account 3243 to offset general fund appropriations for Medicaid expenditures, and is a companion to decision unit 678 in budget account 3243. We're requesting this decision unit as a part of the division's requested budget reductions, and we're currently projecting a general fund surplus and seeking your approval to balance forward the state net benefit for fiscal year 2021 to be used in 2022. This concludes the major decision units for this budget account, and we'd be happy to address any questions that the committee may have.
Thank you so much for that presentation. Before we move on to questions, I would just like to let our committee secretary know that Senator Canizero has joined the meeting. I forgot to tell you as soon as she got in, but I'd like to show her as present. So on to questions. I believe we have Senator Dondero Luke with a few questions.
Thank you, Madam Chair, and thank you for this presentation. I know how convoluted and important this information is. Can you describe the differences between the Managed Care Organization Enhanced Payment Program and the Managed Care Organization Direct Payment Program?
Good morning, Phil Burrell, Deputy Administrator for the record. Good morning, thank you for your question. So the primary difference between the two is essentially the change in federal requirements for the previous program, the MCO Enhanced program, to the requirements for the MCO Directed Payment program. And what this entails is what Administrator Bierman was highlighting was in 2016, CMS released additional guidance to give us further direction and understanding on how to proceed with this pass-through program. Through that, we worked with UMC and Clark County to reprocess for the IGT program to allow us to focus on essentially this new program for directed payments that would allow us to be more in line with the with quality as well as directed services. The way this would work and the way this will continue to work is it allows us to get better focus on and better meet updated CMS federal requirements.
Thank you very much for that. Follow up, Madam Chair?
Go ahead.
Would you please be able to also confirm the reductions in the state disproportionate share hospital allotments that have been delayed until October 1st, 2023, which would provide the hospitals with additional DSH payments? And I think it was 130 million over the 2021-23 biennium.
Good morning, Phil Burrell, Deputy Administrator for the record. Yes, ma'am, this disproportionate share hospital payment allotments are being pushed back to that date, as you said, 10/1/2023. And the reason for that is from end of last year, the Consolidated Appropriations Act passed by Congress included the language for making this change happen.
Okay, so it was congressional issue, decision. Thank you. Thank you, Madam Chair. I appreciate the time.
Thank you. Assemblywoman Titus.
Thank you. And thanks for your presentation and try to get some clarity here. But it's my understanding that these payments, these MCO directed payments are actually provided to Medicaid participants and are associated with quality measures. And actually the number of Medicaid participants that are seen or taken care of or visits, it's always, I need a clarity here and I need some numbers because at the early part of this presentation, we saw the increased number by 20% of Medicaid enrollees. This particular budget involves actually Medicaid participants and perhaps their treatments. How much has the patient interaction numbers increased? This budget just means that you're getting more money because you have X number of people there, but I want to see how many contacts, how much care was actually given. And I want to see if that number increased because my perception that the actual patient contacts, patient visits, patient hospitalizations have gone down. And so I just need to see some numbers what this reimbursement is tied to. Actual patient direct services, not a presumptive services, direct services, hands-on.
Thank you for the question, Assemblywoman Titus. We do have utilization reports and we'll be happy to follow up and share those with the committee. I can say that we did look at this from a very high level on a per capita basis recently, and can say that we saw a slight decline in utilization between 2019 and 2020 when you looked at it, again, accounting for the huge enrollment growth that we've had over the course of the past year. But when we analyze the data looking at a per capita basis, we did see small declines in utilization over the course of the past year. So we're happy to follow up and provide the committee with that report. And if there are other specific services and utilization of particular services, we have that information as well. We'll be happy to provide.
Great, thank you. Follow up, Madam Chair? Because I appreciate that. I'm sure every member of the committee would like to actually see the utilization because, again, these are direct services. And along as when you get that report, the thing, and later on we'll see reimbursements to physicians and some other budget, but included in that report is if these are all about direct services, it would be important to know, again, how many increase in providers you have enrollment and maybe a reimbursement turnaround time. The earlier question regarding that reimbursement to the facilities that Senator Dondera-Loop asked about the delay in getting these payments to these facilities. It's all about access to care. And you mentioned that there's no delay in access to care. Well, if these facilities close because they haven't gotten their payments, that's going to be a huge access to care issue. So I think all of that information is critical. Again, we need more details than just the number of enrollees. Thank you, Madam Chair.
Thank you. Assemblywoman Carlton.
Oh, thank you, Madam Chair. I think my questions been asked. I'm going to hang back and go from there. But along the line of Dr. Titus's questioning, I know that's kind of how managed care works. It's sort of a safety valve for the state that we funded along the lines of a per member per month sort of formula, and that sometimes the provider does well or the facilities do better, but it does protect the state. So I think what we're talking about is just generally how managed care works, and all it would take is a couple of $1 million babies to kind of blow that formula out of the water. So I believe that was the biggest discussion point we had years ago as we moved to managed care. So I just think that needs to be part of the conversation also. Thank you very much for the statement. Appreciate it.
Thank you. Senator Keffer.
Thank you, Madam Chair. Thank you, Ms. Bierman. With the extension of the DISH program, there should be some extended and benefit. Our staff indicates it's about $24.2 million over the biennium that's currently not incorporated into your budget request. Do you agree with that number?
Melissa Loffer-Lewis for the record. So our staff are currently working with the recently extended DISH reductions or postponement of the DISH reductions. We will require a reprojection of that program as well as the associated state net benefit. So in working with LCD fiscal staff, we will provide those updated figures with our caseload and FMAP updates next month.
Thank you for that. And we also understand that you're carrying forward about $2.4 million in state net benefit from fiscal year 2020 that wasn't expended. That would be available to us in the first year of the biennium. Do you agree with that too, or is that included in your reprojection?
Melissa Loffer-Lewis for the record, that is correct.
Thank you.
Assemblywoman Benitez Thompson, did you have a question? Okay. Members, any other questions on this budget before we move on? All right, seeing that.
Madam Chair, if I could hop in real quick, though, since we're talking about this is Assemblywoman Carlton, and I didn't want to go there unless somebody else asked, but as we look at the disproportionate share, the impacts that hospitals have had, especially in this past year, when we were looking at these budgets, did the money that came from the federal government to help the hospitals weigh into any of these decisions? And I don't see any of those discussion points included here, but I do know that there were dollars that did go to the hospitals to help them get through the pandemic because of the way their business actually ended up running. So was that part of the discussions as you put some of these things together? I'm not sure if it's appropriate here, but because we're talking about disproportionate share and impacts to hospitals, I thought I might ask it here.
Thank you for the question, Assemblywoman Carlton. Well, for the division, the primary place that we saw additional funding from the federal government was from the Families First Coronavirus Response Act, and that is a 6.2 enhancement of the FMAP for the program that we've been receiving since 2020. In addition to that, the federal government did also administer what's called a Provider Relief Fund, and that's separate from the funding that came into the division, but worked very closely and tried to provide a lot of outreach and education to providers, hospitals, and actually a wide range of Medicaid providers to let them know that additional funding from the federal government was available through the Provider Relief Fund. So we could follow up with additional information regarding the amount of money that came into Nevada through that Provider Relief Fund, but specific to the division, the primary enhancement that we've seen in our budget has been in that enhanced FMAP through the Families First Coronavirus Response Act.
Thank you very much, Madam.
Thank you, Assemblywoman. And getting that information would be extremely helpful. So if you could provide that to the committee, I would appreciate that.
Absolutely. Happy to do that.
Seeing no other questions on this budget, we will move on to our next budget, 3158.
Thank you, Suzanne Bierman, for the record. Budget account 3158 is the Medicaid administration account. So this is the account with the decision units that really fund the administrative and operational aspects associated with the state's Medicaid program. So happy to go through all of our major decision units in this budget account. Here we just provided this graph related to waiver caseloads, and we'll talk about this more in the Medicaid medical budget when we get to it too, but there are some administrative costs associated with the increase in waiver caseloads. So did just want to provide this slide here, and on this chart, the green section of this graph is related to anticipated caseload growth, and the orange section here is the additional caseload growth beyond that that is being requested to comply with Olmstead and ensure no one is waiting more than 90 days. Again, a lot of this is more applicable to the medical services budget, and we'll talk about it then too, but as we're jumping into some decision units related to waiver caseloads, did just want to provide a little bit of context on this as well. Next slide, please. So these are the decision units that we are seeking to address the administrative costs related to the increases in waiver caseloads. And these are things like quality reviews, processing eligibility for waivers, and compliance monitoring and oversight. Those are some of the administrative tasks that go along with the waivers and the increases in caseload. Next slide, please. So here we have, again, there are two distinct requests related to the waivers. One was the wait list reduction. This one to meet the waiting list and the additional slots that are being requested to address Olmstead related issues. Again, all of these amounts are related to the division's administrative costs related to the waivers and these increased in slots or caseload. Next slide, please. Okay, on this slide, we have a couple of our IT initiatives. The first of these is related to interoperability. Medicaid providers have many different data systems, and here we're requesting funding for the administrative costs so that we can ensure that the data systems talk to each other. And from a consumer perspective, the feds are requiring what is being called an application programming interface, or an API. So the division here is requesting funding in this decision unit to comply with that federal mandate. They are related to the development of these APIs, and do think that this has value for consumers and making their data more accessible. So that is M517. M518, the second decision unit here, funds contracts for the continued implementation of the state's electronic visit verification system, or what we call EVV for short. And that's also a federal requirement that we're working to implement that allows the division to automatically verify that recipients are receiving services that they're entitled to, specifically in the long-term care and home and community-based services. So, next slide, please. This slide brings us to additional enhancements related to health information technology funding. And the first of these does request funding for a contract to move health data from electronic health records into a repository for care coordination and population health management. The next decision unit, E226, MMIS modernization project, is something I know the committee has heard a lot about over the last years. Maybe, I don't know if it's an exaggeration to say a decade, but these are definitely long IT projects in the work and massive undertakings for the state. And happy to report that the state has had a really successful MMIS modernization. And this is just the last remaining piece of work that is related to the state's MMIS modernization project. Almost completely done, certainly expect it to be done in state fiscal year 22, but did just want to flag that is related to the MMIS modernization project that has been underway for some time. Next slide, please. Okay, on this slide we have several decision units related to some administrative costs to fund. The first one is for a medical loss ratio review study. The division is seeking to hire a contractor to review managed care plan submissions related to their medical loss ratio. There is a federal requirement that the managed care plans spend at least 85% of their net revenue on medical services, and the division here is looking to fund a contractor to review those submissions. And it's important because if that threshold, the 85% threshold that I mentioned, is not met, a remittance is due to the state. So just looking for some extra support to dive a little bit deeper into those MLR reports and ensure that requirement's being met. The next decision unit here, E228, is seeking funding for a pharmacy benefit manager, a separate contract. Currently, those services are provided through an overarching contract that the state has with a fiscal intermediary, Gainwell. And this particular decision unit will allow the division to have more control over the benefit by having a direct contract with a pharmacy benefit manager. And the last enhancement outlined on this slide for TMSIS data quality, I hope that we have defined that acronym. It is escaping me at the moment, but I can say TMSIS is a data initiative that's been very important to our federal partners, the Centers for Medicare and Medicaid Services. It's been one of their longstanding priorities, and also important for the division because it allows us to improve our data quality and have some efficiencies in our reporting, and also have data that helps inform policy decisions. So we are seeking one new position to help with those data quality efforts and ensure that we stay meeting all of our TMSIS requirements and work to improve our data quality going forward. Next slide, please. Okay, that brings us to the decision units related to the certified community behavioral health centers. And here we're looking for contracts to assist with rate setting and quality incentive payments that will help us improve our quality and make sure that the rates that are funding those critical certified community behavioral health centers are adequate and on the mark. So that is E350, and E351 below is seeking assistance to fund actuary costs related to restoring the 6% rate reduction, need to have some actuarial help and with the managed care component of our program, and ensuring that as is part of the governor's recommended budget, the 6% rate reduction that was made during the 31st special session is able to be restored and have the technical support needed to update our cost to managed care as a part of that. Okay, this decision unit is related to cost allocation. This funds revenue adjustments that we transfer to multiple state agencies, things like the Division of Welfare and Supportive Services does Medicaid determinations. So really just funds the work to make sure that we have appropriate cost allocation plans in place. Next slide, please. Okay, this slide outlines the position changes that the division is seeking during this biennium, and they are all listed on this one slide. Two of these are related to clinical transfers from the Division of Public and Behavioral Health to the Division of Healthcare Financing and Policy. The last three are related to QA efforts from DHCFP to ADSD. Next slide, please. So this slide just provides a high-level summary of the positions that we just went through. As you can see, the overall effect is that the division would be down one position given those transfers. So I believe that is the last slide in our Medicaid administrative account, and concludes all of our major decision units for that budget account. And with that, we'd be happy to address any questions that anybody has.
Thank you. We have a few questions. I will ask members to mute their mics if they're not talking. I will start the questioning with Senator Ratty.
Thank you, Chair, and thank you, Ms. Bierman. There's always a lot in this budget. So I'm going to try to focus my questions on some of the professional and clinical personnel that you're they're in some of these decision units, 229, 400, 501, and 901, I believe. So just starting with the dental health officer. So I'm grateful that we've found a way to have a sustainable funding source for this, but I do want to dig into any consequences, intended or otherwise, that might come from moving them onto this particular funding source. So is there any impact to the actual oral health program or oral health in the state by shifting this out of DPBH and into the Medicaid budget?
Thank you, Senator Ratty. Cody Finney, Deputy Administrator, for the record. You know, the work of Medicaid really is largely improving access and improving the quality of healthcare as we've moved into the ACA era. And so in order to have that work for us, it's incredibly helpful for us to have expertise like a dental health officer that can inform our policy and make sure that the policy we have is clinically sound, make sure that the partnerships that we're building, for example, with our Medicaid, our managed care partners, our dental benefits administrators, that those are directed at the most effective clinical services. We've had a lot of success in aligning the benefits that we do currently provide with updated clinical practice and working with the dental officer currently. And the benefit of that, as we serve that 25% of the population that's with us now, spreads then to the rest of the community because we have an improved network for Medicaid. It improves the network broadly. So from my perspective, having worked on both sides, we're really seeing a lot of overall benefit that will continue from what the oral health program had started years ago, that will continue through and benefit largely the Medicaid population, but really also the entire network of and access to oral health care in the community. Does that help?
Yeah, that definitely helps. Just a technical question. This position has been appointed in the past by the Department of Public and Behavioral Health. I think that might actually be in statute. Do you see that I need to shift that over to an appointment from this division?
Thank you, Cody Finney, for the record. You know, it was our intent and not asking for a change in that statute to collaborate with our sister agency at DPBH. We perceive that could be done successfully either by that appointment being made from DHCFP or at DPBH. So that was the purpose. But we are happy to work with that as this body sees fit.
Great. And so then sort of same question on the similar questions on the Medicaid pharmacy advisor position. How does that help Medicaid?
Good morning, Dwayne Young, Deputy Administrator over Programs. For the record, Madam Chair, through you to the Senator Ratty. In the same vein as Ms. Finney has pointed out, the pharmacy benefit manager managing 25% of the population is really going to help drive the initiatives for where the department wants to go in managing the cost of high-cost drugs. Starting through that, managing both the program from the oversight of the fee-for-service program, also through managed care. We will be talking later about our pharmacy benefit manager contract and moving to a combined contract with the ADAP program, the AIDS Drug Assistance Program, for the Division of Public and Behavioral Health. That will not only increase the state's buying power, but use Medicaid really as the force and the core to drive the mission throughout the state. And look at other state models such as Ohio, where they have a combined PBM for many of the state's functions and move that beyond the state. And so moving the pharmacy benefit manager position to Medicaid just makes sense because that is where you will have your most powerful drive for the combined purchasing power of the drugs, where the state's roadmap wants to be.
And how do they work with or complement the Drug Abuse Review Board and the Silver State Scripps Board?
So the senior pharmacy advisor serves really as the clinical portion for the staff of the Division of Healthcare Financing and Policy. Because the DIR board sets the utilization criteria for the drugs that are FDA approved, as well as with Silver State Scripps, taking into account what is preferred and not preferred. Senate Bill 378 from the last session allowed us to discuss cost for the first time, but that is secondary to the clinical criteria. And so the pharmacy benefit manager is really, even though there's clinical expertise within our fiscal agent and their sub-vendor, they're really there to guide the clinical direction of the policy and to help myself, the deputy administrator, and the chief over pharmacy make the best decisions and ensure that the clinical criteria is really at its highest standard and is not just taking that cost into consideration, but doing what is right for all Nevadans.
Thank you, Mr. Young. And then I guess kind of last question, since this is all about the money. For example, with the state dental health officer position or any of these clinical positions. Sorry, I think I was on mute. Just like last question. My apologies. Last question, because this is all about the money. Just on a dental health officer, are we confident that it's a 75%, 25% match as opposed to a 50-50?
Suzanne Bierman for the record. Senator Ratty, we confirmed with both our counsel, the Deputy Attorney General's office, and the Centers for Medicare and Medicaid Services. There is a federal regulation that allows the division to collect clinical match, which is paid at a 75% federally funded rate for both the dental position as well as the pharmacist position.
Thank you, Chair. That's the end of my questions.
Thank you. Assemblywoman Carlton.
And thank you, Madam Chair. And I guess my questions are going to focus around the pharmacy benefit manager contract and where we're going with that. At the IFC meeting that we had in December of last year, gosh, it's not long ago, but it seems like a very long time ago. We've had a lot of conversation about a carve out and the impact that that would have to the state general fund. So I guess I want to get an update on where we are. I'm not sure we got a definitive answer on those questions. And I guess I really want to have something on the record that talks about the agency's intent on that carve out prescription drug benefit for managed care, because it will have a significant general fund impact. So if they could address that, please.
Suzanne Bierman for the record. I'll start and others may have additional information on this one to add in, but I can say that we heard the message of this body loud and clear and are working to go back and analyze and evaluate the overall impact of that particular policy option, collecting more information, realizing that it does have significant impacts outside of the division on the state's budget in terms of premium tax revenue. So currently working on that analysis and to provide a commitment that we're not moving forward in the near term without additional consultation and providing that additional level of analysis.
And if I may, Madam Chair, so what's the time frame on that? And I'm a little concerned about the word consultation. Something could happen and we may not be in control of the horizontal. So if you could elaborate on the time frame and a little bit more on the consultation part.
So I can tell you previously, Suzanne Bierman for the record, thank you for the question, Assemblywoman Carlton. There had been language to try to move that benefit, carve it out of for managed care earlier in this next upcoming RFP. We've put the brakes on that. So again, aren't moving forward with that carve out at this time. And I'll have to follow up with fiscal unless they're able to provide additional details on the timeline related to that additional analysis today. But it's not our intent to move forward with that at this time, and definitely want to provide further information related to the impact that has on the state premium tax and other factors.
And Madam Chair, I'm sorry if it sounds like I'm beating the proverbial horse, but when I hear at this time. So Ms. Bierman, is your definition of at this time this biennium? So this will not have a discussion through this biennium, and it will possibly be discussed as a change in the next legislative session? Is that the goal?
Suzanne Bierman for the record. Yes, I think that is our goal, unless there's, it's included in our budget for this time. There's not an intention on our part to move forward with that, absent that being decided in our budget for this biennium. Otherwise, it would be for a future biennium.
Okay. And Madam Chair, just to make sure we have a very complete record, time has taught me a number of very tough lessons. Medicaid does have the opportunity to change how they do things through CMS. So I just thank you for the latitude of being able to get some things on the record. I think this is a big policy shift and could have some implications. And I think everyone needs to be aware of those before we make that decision. It might be the right decision in the future, but I think we really need to have the data to make that decision. So thank you very much for the latitude of getting everything on the record. Thank you.
Thank you. Senator Hammond?
Thank you, Madam Chair. I just have one question, Ms. Bierman. Regarding your PBM, I want to go back and kind of that discussion. Recently in the last few sessions, we've had a lot of discussion on what the PBM does.
Senator Hammond, we can barely hear you. Could you get closer to your mic?
Hold on. Can you hear me now?
Yes.
Is that better? Okay.
That's better.
So Ms. Merriman, over the last few years, we've had a lot of discussion about PBMs and pretty much the whole transmission of drugs from manufacturer to the seller to the buyer. And we've talked about transparency. In your estimation, actually, how you vision the way the PBM would work for the state, can you see them also being asked to adhere to all the transparency regulations and laws that we've passed and may pass as well? How transparent will their work be to the general public?
Thank you for the question, Senator Hammond. What's being proposed here is a direct contract for the Medicaid fee-for-service population with PBM. We do think that there will be more transparency because currently those services are handled through a larger contract that then subcontracts to a PBM. So we think by moving to a direct contract, the division will have greater transparency into the workings of the PBM, and the goal is certainly to have increased transparency and would certainly require our vendors to comply with any state and federal laws that are passed. So.
Thank you.
Thank you. I think we have a few more questions. Assemblyman Watts?
Oh, stuck on mute. Thank you, Madam Chair. Yes, I was just wondering, have any programmatic efficiencies been identified since the electronic visit verification system was deployed?
Good afternoon, Dwayne Young for the record, Deputy Administrator for the Division. Madam Chair, through you to Assemblyman Howard Watts. We have not identified any systemic changes from this policy. Nevada was one of the leaders and one of the first states to implement, and so my team has presented at several national conferences. What we found is just general trepidation. Many people believing the government is tracking them. Facilities willing to give variances to longtime staff and provider caregivers who are hesitant about using technology. And so we have been slowly troubleshooting and diving into these cases. And then once we have more systemic data, we'll be able to look at policy changes. I think really the intent of electronic visit verification is to prove that the services are happening. And so we're not seeing large amounts of fraud, waste, and abuse currently. And there's no major active investigations into those. And so that's really what we want to see from this program, is that people are getting the services that they say they're getting.
Great, thank you for that. I also had a question about the M517 decision unit. What's the status of application programming interfaces, associated technology?
Good morning, Philip Burrell, Deputy Administrator for the record. The status is we are in the implementation process now. Beginning in March, we will be moving forward with the project to implement the decision unit we're talking here about, M517. We have an expected go live to be at or before July 1st.
Great, thank you for that. I also had a question about the Health Information Exchange, E225. Would the agency move forward with these projects if they do not obtain a donation to meet the non-federal share of the costs?
Good morning, Philip Burrell, Deputy Administrator for the record. This is in relation to, this decision unit is in relation to our Healthy HIE exchange here in Nevada. As part of the program, it is required for us to have CMS approval of this. And so CMS, and it is currently in review right now, if there is a determination that the approval process is unsuccessful, then no, we would not be able to move forward.
Okay, thank you. And then I have one last question on the modernization project, E226. So I just wanted to get some clarity on the record. Is the project expected to be fully complete in fiscal year 22?
Philip Burrell, Deputy Administrator, again for the record. Yes, the project is, the modernization work with the systems enhancement is complete. This is the final project, the final contract for this project. And essentially what it's doing is we've been wrapping up the post implementation in regards to the project management.
Thank you for that clarification. And thank you, Madam Chair, for the indulgence.
Thank you so much. We have one final question on this budget. Assemblywoman Benitez Thompson.
Thank you so much, Madam Chair. So my question is on the new data quality position, the business process analyst position. It's like we're in requirements with the federal government for, or we're in compliance right now, but it also looks like I think it states 71 data quality issues waiting to be resolved. So imagine that this position would make it so that those quality issues are completely resolved. And then I guess if you could give me some insight into what those quality issues are, whether they're just reconciliations and billing or coding is among like in the MCOs versus fee for service. I thought if you could give us that on the record as to what those are.
Good morning, Philip Burrell, Deputy Administrator for the record. I'll begin, and then if the team has any additional comments, we can definitely try to add additional information for you. Yes, ma'am. The program, this position is as part of the team effort here, if accepted, to be able to be a part of our data quality team to focus on and improve the data quality as part of our teams as Administrator Bierman spoke to earlier today, reporting and data quality. As you mentioned, we're continuing to work with the updated information for CMS federal guidance on the support for the data quality and submission and reporting as it relates to our federal reporting. And so as a part of this effort, with this role in this position, this will be a part of that data team that helps with managing the traffic and the reports and requests that we need to fulfill for our federal requirements. And yes, and that is in compliance. Excuse me, I forgot to mention that. To keep us in compliance with data quality reporting.
Sorry, I lost a piece of that, just the sound.
Again, Phil Burrell, Deputy Administrator, apologies for the sound problem. The role and position here is going to be a part of the data quality team, if approved, to allow us to continue compliance with federal requirements for this position and for our teams is the transformed Medicaid statistical information system that Administrator Bierman spoke about earlier on this decision unit. And it is for us to continue to meet federal compliance as we continue to enhance in the data quality.
Sorry, Madam Chairwoman, I think I'm gonna just see if IT can address the sound issue, because I don't know that I'm picking up the sound very well. I don't know if that's an issue for all members. I don't think it's coming from the department.
It is an issue for all members. Sounds like a helicopter or something landing.
And I'm fine with some written follow-up. I just didn't, I wanted some more insight into what the data quality issues were, since so much of that data, like utilization, like claims and expenditure data, we rely on to make decision numbers. So I just thought it would be helpful for the committee to have a little bit understanding of what those quality issues might be, and then how this business analyst process position might help us with better quality, what the outcomes of that would be. And that can all be responded to, written to staff.
Thank you. Well, it looks like the sound issue has gone for now. I believe Assemblywoman Carlton has a follow-up.
And thank you very much, Madam Chair. On the Medicaid Management Information System, this has been a very long project. It was initiated in 2007. And I just want to congratulate folks for getting through it. It hasn't been easy, but we have seen other technology requests not go this well in the state. So we are on the downhill side of this. It'll be done, it looks like, in 2022, which is fantastic. If you'd have asked me to bet if it would have been this smooth back when we started, I would not have laid money on this one, but I just wanted to congratulate them on getting this project done because it really will make a difference as far as the system goes. So congratulations on getting this huge project completed.
Thank you for those comments. Members, any other questions on this budget before we move on to 3160? Okay, seeing none, then we can proceed to budget 3160.
Record. Can you hear us? I'm still not sure if our audio issues have been resolved. Are we good?
We can hear you. There is a little echo, but we can hear you. It's better than it was.
Okay, thank you. I think there's a fan or something that is blowing in this room, and we're trying to resolve that on our end. So we appreciate your patience. So BA 3160 is the increased quality of nursing care budget account, also known as the skilled nursing facility provider fee. The goal here is to improve long-term nursing care, and this is funded by a provider fee revenue. There is a maintenance decision unit here, M150, but there are no caseload changes associated with this. So again, apologize for our technical difficulties. I think we're in the right place and our audio has been resolved. So again, thank you all for your patience with us, but happy to answer any questions that the committee might have on budget account 3160.
Thank you. We do have a few questions. We'll start with Senator Dondero Loop.
Thank you very much. I actually think the sound sounds like an ultrasound, which is so my question is, what's causing the accumulation of the excess reserves in this budget?
Good morning. For the record, my name is Shirley. I'm with the Division of Healthcare Finance and Policy. There generally are not what you would consider a reserve in this account, but this account continues to collect funds throughout the state fiscal year. And then once we have finished collecting funds for the state fiscal year, we go back and reconcile to determine if the providers have overpaid any taxes. At that point, we refund if there's an overpayment due. But there's not really a reserve. The program continues to operate throughout the year.
So before you ask your next question, could you make that statement again? At the beginning of your statement, there was some background noise. It got better towards the end. So could you just answer the question again for us so we make sure we get it on the record?
Absolutely, thank you. For the record, Sarah Lamb. This program does not have it's not a reserve in a traditional sense because we continue to collect provider tax payments throughout the year, and that can cross over fiscal years.
Okay, so is there a way to maintain that budget? I don't want to call it a reserve then. Is there a way to maintain that budget at that 900 level or below?
For the record, Sarah Lamb, we do not allow the reserve to go below 900,000, but it is very unlikely that there will ever be $900,000 in that account because we're continuing to collect throughout the year. And then as we have enough in the account to transfer the non-federal share payments to 3243, we do that. So there's really no point in the year, just because of the nature of the program, that it will ever be at $900,000.
Okay. All right, thank you.
Assemblywoman Toles.
Thank you, Madam Chair. My questions were answered. Senator Dondero, thanks.
Thank you. Members, any other questions? All right, seeing none, then we will move on to our next budget, 3178.
Great, thank you. Moving on to budget account 3178. This is the budget account for the Nevada Checkup Program, which is what we call the Children's Health Insurance Program here in the state of Nevada. It provides coverage for thousands of low-income, uninsured children who aren't eligible for Medicaid because of the income limits associated with that program, and Checkup serves a slightly higher income population. So we will proceed and go through the decision units related to Checkup. Next slide, please. Okay, here we have M101, which is related to agency-specific inflation increases. So we are requesting projected rate increases for capitated payments and for fee-for-service expenditures for a variety of services, federally qualified health centers, rural health centers, pharmacy, and hospice. So you can see that outlined here at M101. Next slide, please. Okay, this is our first caseload slide, and these projections were done by the Office of Analytics, and it does provide caseload forecasts using data from the Division of Welfare and Supportive Services. I will say that the projections are expected to be updated in March. So we're looking forward to that, and know that in this uncertain and volatile time, it's been a little hard to predict caseload, but here we have what's put together at the end of last year, reflecting the best information available at the time by the Office of Data Analytics. And we use this information to determine a cost per eligible per recipient, and this is then used to budget medical expenditures. Next slide, please. Okay, so again, this just outlines the increases for caseload here, M200 and 201, and provides a little bit more specific detail around our projected caseload for CHIP in these two decision units. Next slide, please. You'll see companions to these decision units in the Medicaid medical services budget as well, but going back to the special session, the December the 31st special session, E351 funds rate restorations for those 6% rate reductions to rates that were included in the fee schedule that the division reduced to address the economic crisis. And the governor's recommended budget does propose restoring those rates effective October 1st, 2021. And you can see that information here. The next decision unit is related to funding for the Managed Care Supplemental Payment Program, the Directed Payment Program that we talked about earlier. And this is a companion to E352 in the IGT program, which was in budget account 3157. Next slide, please. Okay, this slide outlines two of the proposed service eliminations as part of the reductions the division is proposing to meet, the continuing economic crisis. These services have been identified: basic skills training and psychosocial rehabilitation for elimination, and these decision units outline those requests. Next slide, please. This last slide is the third service that we propose to eliminate in the Nevada Checkup Program, and this one is for biofeedback and neurotherapy services. Next slide, please. Okay, that concludes the decision units in the Nevada Checkup account, and we'd be happy to address any questions the committee has about any of those decision units.
Thank you. We do have a few members with questions. We'll start with Senator Dondero.
Thank you for recognizing me, Madam Chair. So can you tell me why the caseload is lower than the legislatively approved budget? The legislative approved one we had in the 2019-21 biennium?
So that is a trend that we do expect to see as the economy worsens, given the differences in the income thresholds for Medicaid and CHIP. It's not uncommon when the economy gets worse to see children transition from checkup coverage to Medicaid coverage, which then results in a reduction of usage of the checkup program and an increase in the Medicaid program. So that may be one of the factors that helps explain that.
Okay, and then I see that the checkup caseload's projected to be 9.1% in 2022, but only projected to increase like 2.5% in 2023. And so can you kind of walk me through that a little bit? Thank you.
Thank you for the question, Senator Loop. And I'll start, and if others have additional information, that would be great too. I think that assumption that goes into the caseload projections there has a lot to do with timing around when the economy may improve. And again, as the economy gets better, you see less usage in checkup. Or as the economy is better, you see increased usage in checkup, and as the economy is worse, more usage in Medicaid. So I think that is a reflection of projected economic trends.
Okay, all right. I think that answers my questions. Thank you very much, Madam Chair.
Thank you. Assemblywoman Tolles.
Yes, thank you, Chair, for the questions. And just looking ahead under E682, 684, and 685, and seeing that we're recommending some service eliminations for basic skills training, psychosocial rehabilitation, biofeedback, and neurotherapy. And I remember we had this discussion in the very early presentations at the beginning of our pre-session hearings. And I know that we're basing some of those reductions based on utilization during 2020. And I just wonder if we see as people move back into this bracket, if we're going to see a higher demand for using these services in 22 and 23, that maybe we need to project that there's going to be a greater need in utilization. So perhaps eliminating or reducing them may not be the right course of action. So just could you speak a little bit more to how we're using 2020 figures to estimate in 22 and 23?
Good morning, Madam Chair, through you to Assemblywoman Tolles. I just want to say that with behavioral health services, there is a slight difference in that we didn't really see a sharp utilization decrease in overall behavioral health services. What we actually saw was a stabilization due to telehealth. Because telehealth has always been promoted for behavioral health services. In addition, because the federal allowance allowed for telephone services, and our policy has always allowed for telephone services for case management and crisis intervention incidents. We did see an increase in crisis intervention incidents as well as outpatient counseling. Outpatient counseling is what we wanted to see an increase in because this means that clients are accessing clinically licensed staff for those higher level interventions. And so even in looking at 2019 data, these services have never been allowed by telehealth because they're not really appropriate interventions for telehealth. And so as we migrated to those higher level of clinical services and have backfilled the needs in other areas, it's really a proposed elimination of the services based off of the lower utilization because they weren't available to telehealth, but those higher level services were, and we did see people accessing them.
Okay, so I think I followed you because obviously we can't do neurotherapy and biofeedback via telehealth and so forth and the basic skills training. So you're not seeing that we're going to be utilizing them as much in 22 and 23. You anticipate?
No, again, Dwayne Young for the record, Madam Chair, through you to Assemblywoman Tolles. Again, we look utilization of those outpatient counseling services, as well as we look to see the creation of more
I believe
we're having
we're-
technical difficulties.
I lost sound.
Chair, this is broadcast. I'm going to try to attempt to assist them.
Thank you.
I think we're disconnected.
Chair, this is broadcast. It looks like they are trying to reconnect. I will let them into the meeting once they do so.
Thank you so much.
That's if they can hear us. Can you hear us?
DHCFP, can you please, this is Amanda from Broadcast. Can you please test your microphone when you're ready?
Good morning. Can you hear us?
We can hear you, and there is no background noise or feedback. So, Chair, I think we are ready.
Awesome. Welcome back.
Thank you. I apologize. Technology is not our friend today.
It happens to all of us. It's okay. Go ahead.
Thank you, Madam Chair. If it worked out well because I got a chance to calculate a little bit of math on my end, so maybe I can articulate the question a little better. And I also want to clarify that I understand that these are elimination of these programs, not reductions. And so from my notes, I have that by eliminating these 3 programs, we would save to the general fund a grand total of $239,632. We would also be leaving on the table the matching federal fund, $679,046. And so we're just eliminating 3 programs that cannot be replaced by telehealth that have a direct impact on citizens and leaving a significant amount of federal funding on the table for $239,000 worth of savings. Is that correct? If we approve the elimination of those programs.
Suzanne Bierman for the record. I will start and confirm that the proposal is to eliminate these 3 services. Defer to finance team on the math. And also Deputy Director Dwayne Young on some of the other services that we think can appropriately address the same and similar needs for the patients that we serve.
Dwayne Young, Deputy Administrator for the division. And so I want to clarify that those numbers are based on the checkup budget, but when we look, these decision units are mirrored in the Medicaid budget as well. And so you will see a greater savings of general fund. And that is correct. We will forfeit that federal match, but as with Medicaid, as other services grow, and we see funds shift as we had in 2020 shift to more outpatient, intensive outpatient, partial hospitalization, and crisis utilized services, which are services that are provided by licensed and credentialed professionals, we will draw down more of those federal match dollars for those services.
Thank you, Chair, for the questions, and thank you for the clarifications. Still hope we're able to get more people off of Medicaid, out of those income brackets and into higher income brackets, so they won't need so much of that assistance there, but we can get them closer to being back up on their feet. Thank you.
Thank you. Assemblywoman Titus.
Thank you, Madam Chair. Deputy Young, I just really have to circle back on what Assemblywoman Tolles just asked you, those questions regarding the choices on what you've chosen to eliminate, because from my medical standpoint, there's no way that a teleconference call can substitute for basic skills training, psycho rehabilitation, and biofeedback and neurotherapy. So I need to hear there was 37 people in the one program, 154 in the other program, and 85 in the third program. And you're telling us that you have decided, and I'd love to see the scientific articles behind it, that a telehealth call can substitute for those services? That's my first question. The second question is, you're using 2020 data of access to services. What's the data from 2019 and what's the one from 2018? We know that 2020 was this point in time that folks could not access this care. So are these numbers up or down, or were these brand new programs? What's the outcome from these programs and the services that these folks had? And I'm just not accepting that you're going to eliminate all this and just tell them to have a phone call, and that you're maybe going to pay for some telehealth or phone calls. I mean, I just don't see the A to B to C here on the, and I know that we in our mental health programs, our state is so lacking, and to eliminate some of these, I just don't see the justification. So can you clarify that on number one, the 2019 numbers, and where you have that science behind removing these programs and substituting a phone call.
Again, Deputy Administrator Dwayne Young for the record. Madam Chair, through you to the Assemblywoman, Dr. Titus. Let me clarify a few things that were said in the first statement. These were not replaced by a phone call because these services have not been traditionally allowed, nor were they allowed during the pandemic via telehealth, with the only exception was psychosocial rehab for those under 18 for our specialized foster care population. Because any clinical intervention is better than no clinical intervention at all, even though these wouldn't meet the standard to be done through a telephone call, as you point out. And so I think that answers the question as, yes, there was higher utilization in 19 because we weren't in a pandemic, people were meeting face to face, and there was higher utilization. In 2020, we didn't allow it via telehealth. Where I'm pointing to the higher utilization in telehealth in 2020 is in our clinical counseling services. One of the exceptions that we made as part of our 1135 waiver was to allow for group counseling to happen via Zoom. This is not something that we would have done before, but there were several clinical articles that supported, again, as we know, any clinical intervention any evidence-based clinical intervention is better than no intervention at all. I think what we saw in the trend, and I know we're all aware of, is that with our children and adults, the complexities of the pandemic and just 2020 overall have impacted and caused higher acuity levels and more individuals in crisis. That meant more individuals reporting to our emergency rooms and more individuals needing higher access and levels to care. The elimination of these decision units is really to push people into those higher levels of care through licensed and clinical professionals that I've pointed out before. And so we do want to see an increase in outpatient counseling. We do want to see greater utilization of our certified community behavioral health centers. We do want to see greater utilization of these services. Now, there are some individuals for which recovery may not always be possible. They are in need of that long-term maintenance and services for behavioral health. And so we have two alternative programs. One we'll discuss later for children in specialized foster care, and that's a 1959 state plan option that replaces these services. And there's an embargo in policy not allowing these services to happen at the same time as those services in specialized foster care, because those children have a specific need for in-home services to work with the agency and the foster parents to stabilize those children through crisis stabilization and intensive in-home services. The other need is for those adults and children that need that are not able to cover, that cycle in and out of our hospitals and need the support. These services were never meant. They're rehabilitative mental health services. They were never meant to be long-term services, and so we have long-term services and support. We'll talk a little bit about some changes to PCS, but what we found with personal care services and home health services is that the population of those that are seriously and persistently mentally ill have increased in accessing those services. And so what we really find is that those services of long-term services and supports are more appropriate for helping this population with their activities of daily living and their instrumental activities of daily living, and helping them in that instead of putting them in a rehabilitative behavioral health services, but something more long-term, where immediate recovery is not the goal, but stabilization and daily growth.
A follow-up, Madam Chair? Thank you, Mr. Young, for that clarity. You made a statement just then about you are eliminating these programs so that you could push folks into a higher level of care. And then you listed a few of those programs that you anticipate pushing folks into a higher level of care. And I just have some concerns that, and I would like to really see, again, it's the outcome data that I'd like to see. Do all folks need to be into a higher level and an extended care, or do they need some basic skills training? Do they need that intervention early? And I think that's a discussion we could have offline. And then also, I still would like to see the numbers of utilization from the 2019, and really all the comments that you've made in good faith are to help folks. But I'd really like to see, and Madam Chair, with the commission for the whole committee, some of your strategic planning on how those dots all fit together. So you made a lot of comments, and I trust that you truly want to improve outcomes, but how does that fit? And so perhaps maybe a follow-up on some information on the breakdown of where you're substituting, you're getting rid of this program, but the hopes are that you've extended these other programs. I think it would be helpful for all of us to see really what this is, and not just this little micro vision right now and what we see on our paper. So I appreciate what you're doing. I appreciate that you're truly trying to improve the mental health of Nevadans. But I would really love to see this program's being eliminated, but here's the other things that we are offering, because it sounds like that's what you're trying to do. I just don't see it in these numbers. So thank you for your time, and thank you, Madam Chair.
Thank you. Senator Ratty?
Thank you, Madam Chair. I appreciate the opportunity. I'm staying on the service cuts. So first of all, I do think it's important that there's some context around this, and this would be CHIP, of course, but probably even more so in Medicaid. They just are, parallel across the two programs. So first of all, I wanted to acknowledge that going back to the special session when we were all struggling together in July and August, there was a long list of Medicaid optional services that were on the table. And so I just want to say, as you were trying to address your budget cuts that were requested by the governor during this challenging financial time, that we have worked to manage to not have dental or prosthetics or other significant Medicaid and CHIP funded programs on this list. So just to say, there's some good news in this budget that we don't see because it's not listed as a cut. So then what I believe, if I'm tracking correctly, is these are the optional Medicaid services that you are recommending for as a cut, specifically to help meet the financial gap that we have. And then I think what I hear you saying is that you are choosing these particular services because you think that there are other places within the overall system of care that these families can be addressed. I guess my question is do we actively help folks navigate? So the 37 checkup participants under basic skills training, the 154 under psychosocial, the 85 under biofeedback and neurotherapy, into new programs with a very warm handoff to make sure that happens so that we know that they don't get lost?
Deputy Administrator Dwayne Young, for the record, Madam Chair, through you to Senator Ratty. So what I will say is, and I think Ms. Finney, my colleague, would agree, that managed care has always had a warm handoff in the transition to the services. You'll see typically lower utilization of these particular services in managed care than you will in fee-for-service. In fee-for-service, what we really tried to do through the governor's budget and last year, through the expansion of the community behavioral health clinics, or CCBHCs as we call them, is really give people a behavioral health home. Same as they would with federally qualified health centers on the medical side, is to move clients into these homes and to have a place that looks at the whole care of the person and links to that medical component as well. And so, yes, the transition is to link these recipients into those other services where they can receive services from clinical professionals, but also link them into other services like personal care services if there's a need for assistance with those activities of daily living.
And then just to follow up specifically on that, if we weren't in a challenging budget situation, would you be eliminating these services in order to achieve that sort of strategic direction?
Again, Dwayne Young, Deputy Administrator, for the record, Madam Chair, through you to Senator Ratty. I think if we weren't in a challenging budget situation, I think what you would see is a limiting and curtailing. If you may remember in the 2017 session, we did bring a budget initiative to lower this rate and cut some of the hours on some of these services. And at that time, we were really met with the impetus to have a replacement of services for children within specialized foster care. The division has accomplished that. And so I think regardless of the budget, you would have seen an impetus to curtail some of these programs more and to shape them. I think that has been accelerated due to the pandemic and the state's current budget situation. And so while there probably would have been more training wheels on this, we do think that this is ultimately the direction in which the state needs to move.
Okay. And then final question, thank you, Chair, for the discretion. In behavioral health, crisis stabilization specifically, but more broadly across the behavioral health system of care, we are doing a lot of work to make sure that we are utilizing the workforce that is peers. And I believe, if I'm understanding correctly, that these are services that are often provided by peers. And so I just want to make sure you referenced several times of that elevating somebody up to a higher level of care with a licensed clinical professional, which is of course wonderful when that is an opportunity. But we are also recognizing peers as an incredibly valuable workforce. And so I'm just wondering, if we're eliminating this, are there other places that we are making sure that peers are still part of the solution, knowing that we have a shortage of licensed clinical professionals and knowing that the research is showing that peers can be a significant asset to a behavioral health journey?
Dwayne Young, Deputy Administrator for the record. Senator Ratty, yes, that's an excellent question. I think while peers can perform these codes and enroll in Medicaid, there's a separate set of CPT codes that are utilized for peer support services, as well as having peer support services integrated into our CCBHCs. And so we actually see the role of peers increasing. Obviously this body has considered this many times. And there's a certification process to that. There are regulations involved around that really support the clinical efficacy of the model that the peers. And so the division sees that when we talk about not just licensed professions, but actually panel and when we actually see them certified professionals, we're speaking of peers as well. And we see that as a model that continues to gain support and would not be impacted as they have separate billing codes than from these service eliminations. And I do want to just clarify, if I have just a bit of levity, to clarify that these services can still be provided in the context of an outpatient therapy appointment or a group therapy appointment. So if it's part of the client's treatment plan that a clinician finds it's clinically appropriate to still have them do BST, as Minority Leader Titus pointed out, they can do that as part of the individualized treatment plan and perform those services within the context of psychotherapy. So we're not eliminating or handicapping the peers or the clinical professionals' ability to really work with the client in their treatment plan. We're just altering the service mechanism in which they occur.
Thank you. I appreciate the answers and I appreciate the opportunity, Chair.
Thank you. Members, any other questions on this budget item before we move to our last budget of the day? Okay, seeing none, then we will move on to 3243.
Thank you. Suzanne Bierman for the record. 3243 is the Nevada Medicaid medical budget account. This is the account from which we pay for medical services for the Medicaid program, which we've mentioned now covers 1 in 4 Nevadans. Next slide, please. So just jumping right in and going through the decision units in this budget account. The first is similar to what you saw in the CHIP account, but specific to the Medicaid program for agency inflation increases for the same range of services that we discussed in the checkup budget: pharmacy, hospice, federally qualified health centers, rural health centers, and Indian health services. Next slide, please. Okay. Again, we're to our caseload slides, except this time for the Medicaid budget. These decision units fund caseload changes in the Medicaid program. As we've discussed many times, these projections are volatile and have some implications related to the public health emergency, how long that lasts. This particular projection was done in 2020 and will be updated in March. So just wanted to provide a graphic representation of caseload and the 2 decision units that are on the next slide. So M200 and 201 here are the increases and decreases for caseload in this budget account. Next slide, please. Okay, here again, we talked about this previously, but these are the medical costs associated with the increases in the 3 home and community-based services waiver caseloads. So you can see M202 here is for the waiver caseload increase for the individuals with intellectual disabilities waiver. M203, the increase in the waiver caseload for individuals on the frail elderly home and community-based waiver. And M204 is the requested increase in waiver caseload for individuals on the physically disabled waiver caseload. Next slide, please. So again, this being broken out when we go back to that graph that we did earlier with the green and the orange pieces of the bar graph, one being related to general waiver caseload growth and the other focused on the number of additional waiver spots needed to eliminate the wait list and fully comply with the Olmstead provisions related to the waivers. Next slide, please. Okay, so budget decision unit 350 here proposes to divert the 1.5 cent tax revenue from the Indigent Accident Fund Supplemental Payment Program to help counties with obligations for the long-term care county match program increase, as we discussed a little bit earlier in our presentation. And E351 talked about this again in the checkup, but this is the Medicaid Medical Companion decision unit that here shows the decision unit related to restoring the provider rate reductions that were required to address the economic crisis and passed during the 31st special session. Next slide, please. All right, this slide has 3 decision units. One we've talked about before, but it's related to the Managed Care Organization Directed Payment Program. The next one, E676, is one of the measures that we're taking to address some of the financial uncertainty and a risk mitigation measure related to managed care payments. And as this committee has noted before, the managed care organizations are paid a monthly capitated fee. And this is to fund an estimated recoupment from the managed care organizations based on one of these risk mitigation strategies, which is called a risk corridor. Decision unit 678 here is related to balancing forward the state net benefit from the intergovernmental transfer account 3157. So these are the companions that we talked about in checkup related to the proposed elimination of these 3 services: basic skills training, psychosocial rehabilitation services. I would also note the behavioral health case management services is included here. And on the next slide is the biofeedback and neurotherapy decision unit that proposes the elimination of that service as well. Next slide, please. In addition to those proposed eliminations, we also have some proposed reductions here. E686 proposes reducing the rate. Again, it's a monthly capitated rate that the division pays to the non-emergency medical transportation vendor. And E687 proposes policy changes to the personal care program. Okay, this slide has 3 additional decision units. The first of these 2 will address the budget shortfall by changing the timing of certain payments to the current fiscal year, making them during this current fiscal year rather than in the future biennium. So one of our ways to reduce cuts that would otherwise be needed in the upcoming biennium budget is by making some of these capitation payments in this current fiscal year. And so those are decision units E6 689, and 690. 500, Decision Unit 500 here relates to the transfer of drug rebates that we discussed earlier in the presentation related to our newest budget account. So that concludes the decision units for the Medicaid medical budgets, which is our final budget account, and we are happy to address any questions that the committee may have.
Thank you. We have several questions. We will start it out with Assemblywoman Carlton.
Thank you very much, Madam Chair. And I guess I really want to have a conversation about caseload. I think it's really important for us to analyze what's going on here. I know in a special session, I made a couple of statements about what I was afraid was going to happen. I know there was some discussion in one of the special sessions about thinking that the Medicaid dollars were going to come in higher than proposed, than we thought, and we shouldn't be making certain cuts. But if you look at the dollars that are here, that in this Medicaid program, in this interim, we are recommending $10 billion, 10B with a billion, over the 2020, 21-23 biennium. I mean, that is just huge when we stop and think about it. And this is healthcare for families in Nevada that we want to have healthcare. So when you look at that caseload growth, that it could possibly, I think if you project it out, we could end up with almost 850,000 folks on Medicaid. That's, I think, when we were having conversations about this earlier, it's like 1 in 4 Nevadans. And I believe the driver of this is basically the economic situation on the Strip right now. We have a large group of Nevada families who had excellent healthcare coverage for a very, very long time. And because of the pandemic, that coverage will possibly be going away. Without COBRA coverage in the future to help these families hold on to their current health care, they will just naturally transition over to Medicaid, and then the state will be picking up that cost. So I think I'd really like to have a conversation with folks, the agency, about these projections on healthcare and what investigations have they done to figure out who's going to be accessing it, how are they going to be able to process all these folks, how are they just managing this amount of people without planning for it 2 years in advance can be very difficult. So if they could elaborate on that, it would be very helpful for me.
Thank you for the question, Assemblywoman Carlton. Suzanne Bierman for the record. I really appreciate the question. I think it's critically important. And I think you identified a lot of the factors that are driving caseload in the Medicaid budget. Certainly the economic recession and the lost employment that comes along with that, certainly a factor. Something that I also want to highlight, we've talked previously about the enhanced FMAP that the division is receiving currently from the Families First Coronavirus Response Act, which has been incredibly helpful. That funding is tied to the declaration of public health emergency. I think we had some of these conversations during the special session too, but it's also tied to or has conditions related to maintenance of effort for eligibility. So during the period of time that the public health emergency is in place and the state is receiving the enhanced federal matching funds, basically anyone that was on caseload is remaining. There are a small number of factors for which the Division of Welfare and Supportive Services can close Medicaid caseload during this time period of the public health emergency. And those are primarily, I think that there's 3 exceptions to the general rule, and that is if someone dies, moves out of state, or makes an affirmative ask that their case be closed. Otherwise, anyone that was on at any point during the public health emergency will remain getting coverage through Medicaid and CHIP during the duration of the public health emergency. So the timing of the public health emergency is really critical, and one of the things that state Medicaid directors and other Medicaid stakeholders really pushed for was some additional clarity from the Biden administration regarding how long the public health emergency might last to help provide some additional clarification and information regarding caseload levels and also FMAP levels, and try to provide some additional certainty in state budget. So I guess my overall arching point is that there are a lot of factors at play here. One is definitely how quickly the economy recovers. Certainly we know that there were some employers that kept employer-sponsored insurance in place for a while that aren't able to for the long run, and we are aware and have been working with some of those large employers that you're referring to, and so know that that certainly is a component of what's driving our caseload increase. But as long as the public health emergency remains in place, we can expect to see those maintenance of effort requirements remain in place, and I think should be prepared for our caseload to remain high for the duration of the public health emergency.
And thank you very much, Madam Chairman. And just one real quick follow-up. I know a number of months ago, there was a list out that was shared about what employers actually have a large percentage of their employees on Medicaid. And I know it's inappropriate to call any employer out, but there is one particular employer that was not impacted by the impact and actually has done by the pandemic and has actually done very, very well. And they have a lot of employees on Medicaid. So they have, in essence, cost shifted their employees over to the state, which I believe is a serious concern that somewhere in the future this legislature needs to have a discussion about, because we're supposed to be here for those families that are really being impacted, not being a subsidy for private business that just doesn't want to step up to the plate and be a good corporate citizen and provide health care. I'll get off my soapbox, Madam Chair. Thank you very much for the...
Soapboxes are okay. Senator Keffer.
Thank you very much, Madam Chair. I appreciate that. And probably to piggyback a little bit on Ms. Carlton, I think it's worth noting that as we see these dramatic increases in caseload, you should probably remember too that we have much more restrictive eligibility requirements than a lot of other states do for this program. So that number could be a lot higher. Ms. Bierman, I appreciate you bringing up the Family First Coronavirus Relief Act and its implications. So I want to make sure I understand. With the MOE requirement and the continued eligibility requirement, does that mean that if someone actually becomes reemployed and becomes insured through a private employer, that they sort of stay as a part of our caseload, even though they might be receiving insurance through a private employer?
Thank you for the question, Senator Keffer. It is my understanding that that could happen and Medicaid could be the secondary payer. It is also my understanding during this period that the reasons for which Division of Welfare and Supportive Services may close cases is really limited to those three factors that I mentioned earlier: death, moving out of the state, or asking for their case to be closed. So I think in the situation that you're outlining, that is possible, and that Medicaid would become the payer of last resort in that instance.
Right, but what percentage of this growth that we've seen is into the MCOs, where we're paying a capitated rate regardless of care?
So thank you for the question, Senator Keffer. I will turn to Deputy Administrator Cody Finney and see if she knows that statistic off the top of her head. If not, we'd be happy to find out and see if that is information that we could provide at a later date.
Cody Finney for the record. Senator Keffer, thank you for the question. I don't know the exact percentage. I would say a majority of this population. 75% of our overall program is in our managed care unit, delivery model. And many of the folks who are impacted, as Assemblywoman Carlton described, by losing their job, and in the area, particularly in Clark County, would go into our managed care program because of the way we have that designed. So we would pay a capitated payment for those recipients. We do have requirements that the managed care programs connect with those recipients, make certain efforts to make those connections, assign them to a primary care provider, do a health risk assessment. So there are some safeguards in place to make sure that people are being connected with health services, and we're not just paying a capitated rate and not getting anything. Pardon me, I'm so sorry. Beyond that, you did see our decision unit looking to get some help with making sure that we are appropriately assessing that medical loss ratio. And we do have the risk corridor in place to make sure that our managed care partners aren't walking away with unreasonable amounts of profit.
I don't know if you saw, this was my hand signal for dual-sided risk corridors.
I'll know that one now.
Okay. So, I mean, you saw where I was going, right? I mean, it's great that we're the payer of last resort, but if we're paying a capitated rate, then we're still having expenses for these folks, even though they might be covered through another source. So I appreciate that clarification. On the, also as it relates to that letter, so we're budgeting caseload based on this letter, right? That we're saying that they're going to extend the public health emergency. So we're going to have this MOE. So this is our caseload projection. But yet we're not using this letter to justify the enhanced FMAP for the rest of the calendar year. So why are we using it for caseload but not FMAP?
Thank you for the question, Senator Kiekefer. I think in the caseload projections, and please, I would invite our finance team to correct me if I have this wrong, but the current caseload projections were predated the letter. So I don't think that they're reflected in the caseload projections today, but will be in that March update. And
So in the March update, our numbers will actually go up because we're going to require MOE extensions for 2 more calendar quarters?
Thank you for the question, Senator Kiekefer. Yes, according to the letter from the Biden administration, the Secretary of Health and Human Services, who is responsible for continuing the public health emergency until it's no longer renewed, they have indicated that they plan to continue the public health emergency throughout calendar year 2021. So that would be for 2 additional quarters of this upcoming biennium, quarters 3 and 4, the first 2 quarters of the upcoming biennium. And again, I think as long as the public health emergency is in place, we can safely assume that we're going to continue to see those high levels of caseload, and along with that does come the enhanced federal matching rate as well.
Right. So when we update this in March with the additional caseload, are you also going to update with the enhanced FMAP for those 2 quarters? My understanding is that we peg that usually at about $30 million a quarter. So that would be about $60 million to the plus for us, right?
That is the statistic. Suzanne Bierman, for the record, thank you for the question. That has been the ballpark estimate that we've used, is about $30 million a quarter. Certainly due to a number of, what type of eligibility group everyone falls into, and a number of other factors, that's just kind of our ballpark estimate. And we've seen fluctuation as we've gotten those actual quarters of public health emergency enhanced FMAP in, but that is the ballpark figure that we use for estimating future quarters of public health emergency enhanced FMAP under the Families First Coronavirus Response Act. Yes, you're correct, Senator.
Thank you very much. I appreciate that. That's all I got, Madam Chair.
Thank you. Senator Ratty?
Thank you, Chair. So I'd like to go back to the service eliminations and to avoid retreading comments that we had under the CHIP budget that I think applied to both. This one includes basic skills training again, it includes psychosocial rehabilitation again, and it includes biofeedback and neurotherapy again. I think we've had good answers on that, but I think what's new here is behavioral health case management. And certainly, at least in my experience in the community, we can never have enough case managers. And so I am curious, sort of the same conversation that we had specific to this one. Is this a strategic shift to a different kind of service, or is this just plain old budget cuts and we needed to find something to cut? how are we going to be okay without behavioral health case management?
Deputy Administrator Dwayne Young for the record, Madam Chair, through you to Senator Ratty. That's a very good question. And in fact, it does not look like it on this paper, but the division is actually expanding the array of case management services. What we're doing, this is a unit of behavioral health case management that can be done for non-seriously mentally ill and non-seriously emotionally disturbed children that can be handled by community providers, and it was titrated on their ability to receive hours, minimizing each month. Where we're expanding case management services are those that are be able to be formed by governmental entities. And so we have our other 8 existing target case groups, which include seriously mentally ill and seriously emotionally disturbed, as well as bringing on new targeted case groups that focus on pregnant women and homelessness that will be administered by the counties. And so what this is doing is, one, shifting that to the continued state funding. You'll see that represented in ADSD's, DCFS, and DPBH's budget of providing those services and contracting with community partners to perform those services as an extension of their agency. But you'll also see now a migration of these services to be performed by the counties, and the county to form public and private partnerships with agencies. And so those dollars aren't coming from the state, but rather for the county, for them to pay the match and then draw down the federal share to help fund some more ambitious projects, such as housing initiatives and overall connections to social determinants of health.
And so in doing that, do we shift the focus from some of these more functioning individuals who are not in the seriously mentally ill or seriously socially emotionally disturbed categories and have more focus on those who are? Or do you think we'll still be hitting this level?
Again, Dwayne Young, thank you, Senator, for the question. I believe through the creation of some of these other target groups, if they're homeless, but not necessarily seriously mentally ill, as we talked about the tenancy supports that's still coming online from last session, the pregnant women, those that are criminally justice involved, those that have a need that is comorbid with some medical condition, we will be hitting those individuals. If they just need a little extra help or navigation, that's what we rely on the care management programs of our managed care, if they're within managed care, or through our district offices and our very hardworking staff throughout the state that provide that navigational assistance to providers for those that are within fee-for-service.
So, Mr. Young, I absolutely believe that you and the team are being as thoughtful as you can about this. I still have some significant questions, and I think, to some prior comments, I think we need some sort of crosswalk that is really showing, okay, this is how we have done it in the past. This is how we're crosswalking it over to how we're doing it in the future. And this is where we see a new category of folks getting additional assistance. And this is how we see the folks who have traditionally been served in these programs continuing to not fall through the cracks and end up just elevating into some of those higher levels of service. So perhaps that's something that we could ask you to bring back. I guess my other question on this is public engagement in terms of conversations with providers or families to make these decisions. How has that been handled?
Deputy Administrator Dwayne Young for the record. Senator, again, thank you for the conversation. Typically, we do public engagement sessions through public workshops. And then, of course, we are required through CMS to have a public hearing on the matter in which comments can be put on the record. We have not begun any typical engagement sessions when we put something through our budget because as it goes through the governor's budget process, obviously it's confidential. Once it's released to the public, we work one-on-one with stakeholders to answer questions, but we really let things pay out in this public process. And then towards the end, once our budget is finalized, we will start the public engagement sessions through workshops.
Okay, thank you. And then on continuing a little bit on the line of service eliminations or significant cuts, if we could just touch on the personal care services. So it looks like the policy decision is that if you are an in-home caregiver, then your household will no longer be eligible for personal care services. Am I understanding the service cut there?
Again, Dwayne Young, Deputy Administrator for the division. Senator Wright, if you allow me to clarify, you would still be eligible for those services. What you would lose is the assistance with instrumental activities of daily living. And those are really activities that help the person live independently. Obviously, the person is not living independently, so some of those structures, so they would lose some time, particularly in housekeeping, assistance with chores, and some food preparation, they would lose some time in that area because they do have a live-in caregiver. They would still be eligible for assistance with activities of daily living, but the proposal is ultimately proposing is those not with just a home income caregiver would see some reductions on the lower level of care, so those that need the lower level of services. Also, what you'll see reflected in the increase in waiver caseload slots. Certainly, we know that any change in Medicaid services obviously changes services that impacts the budget of aging and disability services. And so opening up those waiver slots is really moving those higher acuity level people who are really meant for more long-term services support, the higher progression into the waiver services, as well as getting the waiver-like services from ADSD. So you'll see some discussion on that next week. But yes, to answer the question, there will be, you will see some of the less hours administered to people who have in-home caregivers, but not a total embargo on them not receiving any assistance through that program.
Yeah, and again, I just want to log some concerns on this particular account. We've had lots of conversation about how do we support caregivers to be able to keep people in their homes, because of course, if we can keep people in their homes, it's significantly less expensive than if they go into a care facility of some sort. And I know that I completely hear what you're saying, that the activities of daily living is really intended to be the piece that keeps the individual supported, but the help with housekeeping, cleaning, shopping is the things that keeps the caregiver supported. And it does sound like for a whole group of households, a support that they have organized their life around will no longer be there. So I would just like to have us continue that conversation, because I think caregivers generally have been put through the ringer. We have all the data that shows that caregivers generally have shorter lifespans and all those things. And caregivers during the pandemic have just been so isolated and so under duress that to start to have things start to turn around and then to say, hey, we're taking away this extra support feels justified, possibly from a budget standpoint, but from the real humans who are involved, I'm going to be struggling with that one. So thank you.
Senator Dondero-Luke.
Thank you, Madam Chair. Can you clarify or confirm for me, did the agency experience a decrease in provider enrollment for any provider types, or note access to care issues for Medicaid participants following the announcement of the 6% rate reduction that we approved during the 31st special session?
Thank you. Cody Finney, for the record. Senator Dondero-Luke, to you through Madam Chair Monroe Moreno. The agency has not seen a decrease in overall provider enrollment or identified a noticeable decrease in any individual provider type since the announcement of those cuts. We do monitor that. Overall, over the last 3 years, our provider enrollment is trending slightly upward. We were able to implement some flexibilities with the public health emergency to ensure that that providers could enroll as easily as possible. So that may have had some impact. I will say we were notified by about 3 providers that they would not continue as a result. They would not continue and would not see new Medicaid patients. Out of the 35,000 that we have, there were about 3 groups. We've had some discussion with other states about their experience, and that's consistent with their experience that while that is a concern, they don't see large decreases in that enrollment. We've also not been able to identify particular specific access to care issues, but we do continue to monitor that, and we continue to work with CMS to improve our mechanisms and our comparison studies, the way in which we are doing those that monitoring.
So with that information, does the agency anticipate the access to care for Medicaid participants would improve following the recommended rate restoration?
Well, Cody Finney, for the record, we would certainly hope, I know for a fact that the providers would be much more satisfied with our program, with those restorations, and much more likely to continue to see Medicaid patients and a higher percentage of Medicaid patients as they had been in the past. But again, we haven't been able to identify specific decreases except for a very few number of providers.
Right. Yeah, I understand that. Thank you. I mean, I guess that's good that we haven't had, that we've only had a few. So thank you very much for your information. Thank you, Madam Chair.
Thank you. Assemblyman Watts?
Thank you, Madam Chair. I had a couple of questions. One is around the inclusion in this budget of utilizing projected savings in fiscal year 2021 from the general fund. And I was just wondering, given the caseload trends that were gone over earlier, how confident are you that the budget surplus will materialize as it's projected?
Thank you for the question, Assemblyman Watts. Suzanne Bierman for the record. I think, we've acknowledged that this is a volatile time and that there are a number of volatile and unpredictable factors in the Medicaid realm. However, regarding this current year surplus, I think we feel reasonably confident given the fact that it's in the next couple of months and it's harder to project out over the course of, say, 2 years than just for the next 4 months. So I think we feel reasonably certain that for the next 4 months, we have a good understanding that the public health emergency will be in place, that we'll be receiving the enhanced FMAP. So at this point, we acknowledge that there are some variables out there that make budgeting for Medicaid difficult during this time. But for the remainder of this fiscal year, I think we feel reasonably certain about those projections.
Okay, thank you for that. And then I know one of the things that was included in the 31st special session was the implementation of a specialty pharmacy network, which was anticipated to generate some general fund savings. Can you give us an update on what the status of that is?
Again, Dwayne Young, Deputy Administrator for the record. Madam Chair, through you to Assemblyman Watts. The specialty pharmacy, as you may be aware, as some of you may have been contacted by constituents, we did hold a public engagement section or workshop to talk about the classes of drugs that we're removing into specialty pharmacy. The 1915B waiver was submitted to CMS. However, it also requires a SPA that had not been submitted and would not be submitted until after our public hearing. The 1915B waiver asked us to address how we would incorporate the Hemophilia Treatment Center as part of, because each state has one, and that's a requirement through CMS. They expressed some concerns during that public workshop, and so we are actively working with them, as well as our subcontractor through our fiscal agent, to come to an agreement to launch specialty pharmacy. We are on track to launch prior to the beginning of the new state fiscal year, so that those savings can materialize in the next biennium.
All right, thank you for that additional clarification, Mr. Young and Ms. Bierman, and thank you, Madam Chair, for the questions.
Thank you. Assemblywoman Tolles?
Thank you, Madam Chair, and I know we're getting short on time, so I'll keep this quick. You mentioned public hearings just in that last answer to that question, and wondering if you also had a process by which you engaged the various policy boards in determining these cuts and changes that you're proposing. Thank you.
Again, Deputy Administrator Dwayne Young for the record, Madam Chair, through you to Assemblywoman Tolles. That's an excellent question. That's a point that we didn't bring up earlier. Myself and my staff attend all of the regional behavioral health policy boards, as well as all the boards and commissions through each of our sister agencies addressing each of the areas of care within Medicaid policy. What is very important, and I think the regional behavioral health coordinators will tell you they've had conversations with me over the years. And one of the strategies that we had talked about before was cutting these services so that we could use the savings from them to increase the rates for other services, to attract more psychiatrists, and licensed clinicians. Unfortunately, because of the impotence of the pandemic and our current budget situation, we weren't able to bring that proposal to the table. But they are not foreign to these discussions of the efficacy of these services and the need to move people into services that are done by certified peers, someone who has an accountability board representing them, and an other arrays of service.
Thank you for the answer and thanks for all the work.
Assemblywoman Benitez Thompson.
Thank you, Chairwoman. So real quick, the proposed increase for the home and community-based waiver slots, absolutely supportive of getting more dollars in, and realize that it's important, in order for us to stay in compliance with the Olmstead Act, to make sure that people aren't waiting more than 90 days and that we have a pathway for people not to be institutionalized and to waive them out of institutions and into the community and those supports. I guess I would just be interested as we move through this process of having a deeper conversation about the staffing side of it, because I think that we could hypothetically fund slots to the nth degree, but without the appropriate staffing on the ADSD side, I don't think we're going to have the resources to actually enroll and move through. I think just like we're seeing right now, where we've got a wait list, despite the fact that we've got approved slots, just speaks to that. So I guess the question I would ask then is, do you think that there's a likelihood that the waiver caseload increases will materialize next biennium?
Deputy Administrator Dwayne Young for the record. Can you hear me? Oh, thank you. Madam Chair, through you to Assemblywoman Vice Chair Benitez Thompson. I think that you'll hear some of that conversation next week in Aging and Disability Services budget presentation. I think it's no mystery that the state is often challenged in recruiting and hiring social workers. And so I think that has always been at the forefront of the department's mind, is making sure that we can recruit and retain staff. But I also think I want to, particularly in the last year, commend staff and for the ways in which they have worked with the current waiver recipients and really organized their processes. And so I know that Administrator Schmidt and her staff will speak to that more directly.
Thank you. And we'll have that conversation there. I just want to make sure that I noted it. The last thing that I wanted to touch on real quick, Madam Chairwoman, if it's okay. And I know we could probably be on this conversation for a good amount of time. And but what I was hoping to do was just have you put on the record, if you could, the timeline of we've submitted the state plan with the recommendation for the cuts of the 6% from special session. Those cuts have not yet been implemented. So we know that there's this lag between our legislative budgets and how we fund, appropriate, unappropriate things, and then how those dollars flow out to providers and hit services in the real world. So I thought that you could just give for us when you thought that our state plan for those cuts might be actualized, when providers might start to see the reduced rates paid to them, and then and when that might all actually kind of hit the ground.
Thank you for the question, Vice Chair Benitez Thompson. Suzanne Bierman for the record. It's a great question, and I'll start, and if others have information to add, certainly welcome that from our team. You're correct. The process is lengthy. We started working on implementing the cuts from the special session in the summer. We're still in process of that. A handful of the state plan amendments related to those rate reductions have been approved and are being implemented. It's the minority. The vast majority are still pending CMS approval. We've been working closely with CMS as Deputy Administrator Cody Finney noted on the Access Monitoring and Review Plan. CMS has this process that they call stopping the clock, where it slows down the normal process when they have additional questions. It's called a request for additional information, or RAI. We've been in a couple of those periods just because CMS does take these issues of access to care very seriously, as does the division. Have been working with others in the state. I want to specifically highlight the Public Employees Benefit Division. They've been extremely helpful in providing us with data and information that's been requested by CMS, just related to their rates and access to care in the state generally. So we are still working through that process, but do want to highlight that our state plan amendments did seek retroactive approval, and we have preserved those dates of August 15th. So we're still working through this process, and we'll implement as soon as we get CMS approval, but do want to highlight that it'll be back to that period of August 15th, 2020, and then with the governor's recommended budget of that being restored as of October 1st, 2021. So that will be the timeline that the rate reductions are actually in place, and we are still working through the process. So unfortunately, I can't say, on March 1st, we're going to flip the switch because we're still awaiting CMS approval on that, but have preserved those retroactive approval dates back to August 15th.
And this is Phil Burrow, Deputy Administrator, for the record. And to follow up with that, just some additional detail. We are actually meeting with CMS weekly on this. We're working with them through the RAI process, making sure we can get them the additional information they need to understand the questions that are asked. As a part of the Access to Care Monitoring Review Plan, a federal requirement when you are pursuing a cut of more or greater than 3.9%, in this case, we are pursuing the 6%. It is required to go through the Access to Care Monitoring Review Plan, where we will ensure and look into the details on access to care to ensure that we're not hurting or detrimenting the state in any way. So we are meeting with CMS weekly, going through the process, and then we'll continue to expedite and move that forward as quickly as possible.
And Deputy Administrator Cody Finney, if I could just beg one indulgence in the interest of full transparency, I do want to make sure that everyone's clear that the payment for our managed care plans, that has been implemented, and the managed care plans have, because those rates changed, so we had to do new rates for our new capitation rates for our managed care plans with that 6% reduction. Those have been implemented, and some of the managed care plans have implemented passing those on to their providers through their processing mechanisms. So CMS is aware of that. Everyone is aware that we're still working through the approval process, and that is something that is allowed. Should something change, then those rates would be reprocessed. But I just want to, in the interest of full transparency, make sure that's clear.
And thank you. And I appreciate that, because I think that helps me to know if a piece of the Medicaid universe is already accounting for those cuts. And if it's MCOs, it's probably going to be a bigger piece. So it's mostly the fee for service folks and vast majority who are still kind of going along with business as usual. And I think just where this is important, and for us as legislators, is as we have the conversation about potentially restoring cuts, we might take that action, but while we're taking that action, in the real world, those 6% cuts will actually be implemented. And so, for, more community providers, or, let those providers who maybe aren't surrounded by lobbyists and lawyers, quite frankly, right? There might be some confusion about how this is all out, because there's such a long lag to how these decisions get implemented. And that's just what I wanted on the record.
Assemblywoman Carlton.
Thank Thank you, Madam Chair. And if I could ask to address the two-sided risk corridor. Senator Kekeffer glanced upon it earlier, but I'm still a bit confused about what a two-sided risk corridor is. So if you could just elaborate a little bit on exactly what the problem is and what we're trying to fix, that would really help me. So just give me those in the interest of time. And then we're just doing this for 1 year for 2020. Do we plan on doing this again?
Thank you, Assemblywoman Carlton. Cody Finney for the record. A two-sided risk corridor is a strategy that is used in these prospective payment models like managed care that allows us to address situations in which it's very difficult to predict, as the pandemic has definitely been. It's been very difficult for the actuaries to make the usual firm predictions about how much things are going to cost, because we didn't know how much the actual COVID care was going to cost. We didn't know how much the utilization reductions from shutdowns would impact things. So CMS allowed in 2020 the implementation of a two-sided of a risk corridor that allows the state and the plans to share what that unpredictable risk will be. So if the plans, if those capitation payments were too high, then the state would get some of that funding back. If they're too low, then the state would seek to have some pay for some of those services. Usually these arrangements have to be done in advance before the beginning of the period. So it would have to be set up, all contracted and done before the beginning of 2020. Because of the very unusual circumstance this year, CMS allowed us to set that up during that rate. We're doing that period. We do intend to continue for 2021 because as we know, this situation continues. But over time, and risk corridors can be used for different mechanisms, but this one is more broad than we've done in the past, and particularly aimed at this unusual period to try to make sure that we're good partners, and that we're also that our partners are good partners to us as well.
And thank you very much, Ms. Finney. And Madam Chair, if I could just follow up with the statement that I heard earlier, that I just wanted to make sure that I understood correctly. Somewhere in the conversation, a statement was made that some of the responsibilities of the next fiscal year are going to be paid for out of this fiscal year. And I'm not sure if we've done that before, and how can we pay for what's going to happen next year out of this year? And if I misunderstood, I apologize, but I think it was in reference to 680 and 690. I'm not sure, but if you could clarify that for me.
Good morning, Melissa Locker-Lewis for the record. So I think a little bit of clarification. So in terms of decision unit E690, this is related to the non-capitation payments that were proposed to be delayed via AB3 of the special session. These are truly state fiscal year 21 expenses. However, because of the budget reductions during special session, we had proposed to process those payments in state fiscal year 22. Given the division's current cash balance, we are able to make those payments within this state fiscal year and are seeking approval to do so.
Okay, I think I'm probably going to have other questions on that, but in the interest of time, Madam Chair, I will take those offline. Thank you very much.
Thank you. Members, any other questions? Okay, just to make sure that I may have missed it earlier, I'd like to ask about our specialized foster care services. I just want to make sure, does the agency anticipate additional general fund costs beyond the amount that was recommended in the executive budget in the upcoming biennium, which is associated with the new specialized foster care services, if the state plan amendment is approved by the Centers for Medicare and Medicaid Services? Did I miss that? Did you answer that earlier? And if you did, I apologize.
Good morning. Again, Dwayne Young for the division, Madam Chair. We addressed specialized foster care, but we did not answer that specific question. And so what we will see is an offset to the expenditures that Assembly Minority Leader Dr. Titus alluded to because of the BST and PSR were used for that population of specialized foster care. We did allow special allowances during the pandemic for PSR to occur via telehealth for children 18 and under. But then certainly there was a dip in services of BST and then an increase because we were not able to bring the specialized foster care system in time. That state plan was actually approved already. We have providers that are going through the enrollment process and the training process. We put together a joint training with the Division of Child and Family Services. In the meantime, what we have done is waived the titration down on those rehabilitative mental health services to support the specialized foster care providers as they move over. Once they enroll, they have 60 days to move over and out of the other provider type, with all providers expected to be moved out of June. So we will see some late year expenditures in the current fiscal year for specialized foster care, but we won't see a skyrocketing effect. And then in the new fiscal year, we will see some expenditures for those services, but knowing that part of those expenditures, because of the case management and assessment component, will be done by the state and county, will be contained within those budgets. And what we'll only be seeing is the service provision. And so I actually believe we'll see a decrease in overall expenditures because we're shifting from that rehabilitative mental health model to this specialized foster care model.
Thank you for that. Members, any other questions? Okay, we're seeing none. Well, we got wrapped up just before 11. That's amazing. I didn't think it would happen. I thank you for joining us here and getting through the 6 budgets. And by the sound of it, we'll be hearing from you again next week. We'll see you again next week. So thank you, Administrator and your staff, and have a wonderful weekend.
Thank you.
Members, that brings us to the last item on our agenda, and that last item is public comment. Just as a reminder for those who are joining us virtually, you may register online to either speak to the committee by telephone, or you can submit your comments to us by email. So I will ask our staff, do we have anyone in the waiting room for public comment?
Hello, Chair. This is Michael from Broadcast. We have a few people in the queue. Would you like me to get the first one on the line?
Yes, please. Thank you.
Caller with the last 3 digits, 120. Please slowly state and spell your name. You will have 2 minutes and may begin.
Good afternoon, or good morning, Madam Chair, members of the committee. Stephen Cohen for the record. Stephen with a V, Cohen, C-O-H-E-N. For the sake of time, I will submit my remarks in writing. With that, Madam Chair, thank you, and I yield.
Thank you. Next caller.
Hello, caller with the last 3 digits, 602. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last 3 digits, 602. Please press *6 to unmute. I'm going to move on to the next caller. Caller with the last 3 digits, 528. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Yes, good afternoon, good morning, Madam Chair. It's almost afternoon, Madam Chair, members of the committee. For the record, my name is Barry Gold, B-A-R-R-Y, last name G-O-L-D, the Director of Government Relations for AARP Nevada. First, I'd like to thank Senator Ratty for her absolute great recognition of the critical role that family caregivers do. We rely on them and the 350,000 of them that take care of older adults. And I'd also like to thank Majority Floor Leader Benitez Thompson for talking about the staffing need to go ahead with caseload growth and the waiting list growth for the waiver programs. But I'm really wanting to talk to you about the waiver programs. For those of you who have heard me talk about this before, those waiver programs keep people living independently where they want to be with dignity, and they're important. Plus, they're the fiscally prudent thing to do. I've talked to you before about that. The Nevada Legislature has been wonderful about funding caseload growth for these waiver programs, but we really need to talk about the waiting list as well. The decision units M203 and M511 have to do with caseload growth and the waiting list for the frail elderly waiver. And it's so important that we fund those because we need to keep people out of those nursing homes. As you heard before, it's much more expensive. It costs about $14,000 to keep somebody in the waiver program as opposed to about $80,000 plus to put them in a nursing home, and we pay for all that. What I want to mention is at the Commission on Aging meeting last time, I asked how many people dropped off the waiting list in this biennium and for what reasons. And I was kind of appalled to find out that approximately 200 people have dropped off the waiting list because they either died or they went into a nursing home. And if they went into a nursing home, that's terrible because it's costing us all more money, and they didn't want to go in a nursing home. They would have much preferred to stay living more independently in the community. And if they died, well, that's just a human tragedy, something that possibly we could have prevented if we'd have found space to put them in these waiver programs. So it's really important that we fund these different programs. And in terms of the waiting list, I know the Olmstead Act talks about 90 days or more, but what I will tell you is there are often people in the waiting list more than 90 days. Some people are on the waiting list more than 180 days. So I'm urging the legislature, yes, on behalf of the 345,000 AARP members, to fund not just caseload growth for the waiver programs, but to eliminate the waiting list. Thank you very much for listening to me today.
Thank you for your comments. Do we have anyone else in the waiting room?
I believe so. Callers, if you wish to make public comment, please press *9 now to take your place in the queue. Caller with the last 3 digits, 602. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning. My name is Eddie Ableser, EDDIE-ABLESER. I would like to thank the chair and the subcommittee for hearing Vision of Healthcare Finance Policies budget this morning. I'm calling this morning on behalf of the Nevada Dental Association. We are excited about the actions taken by Division of Public and Behavioral Health and Medicaid, state Medicaid, in the move to co-locate the oral health program in both DPBH and DHCFP. We believe this will help sustain the program and draw more policy initiatives ubiquitously throughout the state to help oral health and the underserved populations. And so we would like to show our support for the budget item E400 that you heard today, as well as DPBH budget item 3220 and chronic disease and oral health program. Thank you for your attention and support for this initiative.
Thank you.
Caller with the last. We do. Sorry, I didn't mean to interrupt you, Chair. Caller with the last 3 digits, 316. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning. This is Ted Nagel for the record, TEDNAGEL. Thank you for listening to my comments. There were several places during the morning that I would have loved to ask some questions, and I'm going to put them together in an email and add them in. But I would like to address the fact that, number one, I do hope they reestablish the 6% cut that was put in the special session. But even over above that, they need more money than that because the caregivers are being paid so little money that people like me who live in Douglas County in rural Nevada are so short-handed in caregivers because they can make more money going and working for a fast food joint. I was forced to put myself into a care facility for, which I thought was going to be a month or two, ended up being 30 months. I was in the care facility because there was not caregivers available to meet my need. And my wife is physically disabled and is not able to provide my care. Although at this moment, while I'm waiting to get back on the list, she is doing what she can, requiring me to stay in bed every other day or so to be able to just provide to get me out of the care facility because the COVID-19 had attacked that care facility so greatly that there was 10 people in one testing in my hall that were COVID positive. And so I said, I got to get out of here no matter what it takes. And so my wife has stepped up to the plate, which she's more than happy to do, but her physical abilities are certainly giving her a lot of pain and grief and everything like that because she has constant pain, and having to take care of me, who is a quadriplegic, is difficult at best. So my interest is in raising the amount of money that people are paid to be caregivers so that we can get some quality people and not people just looking for a paycheck and taking, we had things stolen in the past because the pay was so little that they had to supplement their pay in some way. So they stole money, they've stolen drugs, and it's because private pay caregivers are being paid $20 to $25 an hour, where the best caregivers under the programs, the waiver program and whatnot, only get like $10.50 an hour. And I myself would probably flip burgers before doing this work for that kind of pay. So I hope that you guys understand that we are out here, a lot of people, and I hope my other cohort who was on the line earlier will make a statement, but we are in the Nevada Disability community group, and we are very adamant about getting better pay for our caregivers. Thank you for your time.
Thank you so much for your comments, and I look forward to receiving your email.
Caller with the last three digits, 717, please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits, 717, please press *6 to unmute.
Thank you. My name is Connie McMullen, CONNIE, MCMULLEN, and I represent the Personal Care Association of Nevada, which is about 30 personal care companies. And thank you very much for your approval and support of restoring the 6% reduction and increasing the waiver slots for the frail elderly, intellectual disabilities, and people with disabilities. Our concern is with item E687, which is in personal care policy reductions that will be limited, modified, or reduced, and that the instrumental activities of daily living will be limited to those only with the greatest need when a caregiver is present. As you know, we are in a caregiver crisis. There are shortages. As Mr. Nagel said, we are really challenged to go out to rural areas, and the caregivers also often work for more than one personal care agency because they have to meet some of the overtime rules. We also thank you for clarification on the payments when the rates were reduced and when they will be resumed or restored. I've been asking and asking because the bottom line is always how much money they're going to get for caring for people, and I just could not seem to get that answer. So thank you. I am amazed at some of the knowledge and the questions that you have asked, and I thank you so much for giving me this time on behalf of the Personal Care Association. Thank you.
Thank you.
To make public comment, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 017, please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last 3 digits, 017, please press star 6 to unmute.
Thank you. Madam Chair, this is Bill Welch, WELCH, President and CEO of the Nevada Hospital Association. Appreciate the opportunity in speaking to the committee. First, I'd like to acknowledge your questions that you were asked today. I think they were right on cue. There were a number of things that were presented today that we would like to respond to, as well as a number of questions. 2 minutes certainly won't allow that, so we will be preparing comments to be submitted to you in writing. This is clearly a very important issue to the medical community, particularly the hospital community, and so we will be submitting questions and comments to you in the next couple of days, and appreciate that opportunity to provide that input to you. I'd also like to acknowledge that we have been working with the State Medicaid Division, and we very much appreciate their openness over the last 6 months working with us, and we look forward to continuing to work with them as well. Appreciate your time today.
Thank you.
Callers, to make public comment, please press star 9 now to take your place in the queue. Chair, the public comment line is open and working. However, we don't have any callers at this time.
Thank you so much. So members, seeing that there's no other individuals wishing to make public comment, that would conclude today's meeting. And I'd like to thank all of our presenters, the committee broadcast staff, and the members of the public who joined us here virtually. So with that, this meeting is adjourned, and I wish you all a wonderful weekend.